emphasize that despite of the increase, it's still very, very unequal in terms of access. At the same time, the issues around optimization is also important in terms of the cascade process, because I discussed a lot about how to optimize the HIV care cascade. And in fact, the issue around drug optimization also can impact in some aspect of this cascade. But again, even in countries that have a good testing, a good access to treatment, the treatment cascades are still not so good. And we will present this data also in the conference. I think interesting to see how the cascades of countries that we imagine that is still very good, but in fact are not so good as we think, particularly regarding viral suppression. Then I think we need really to think more about it and how the treatment optimization can contribute in the process to convert this leaky cascade in a more continuity of care. In terms of drugs, it's also important to emphasize that the process has been evolved a lot. And using this target product profile that Mac commented before, you can see that the way that the drugs have evolved in the last 30 years has been very, very important to see the way that you move from a lot of tablets taken 3-4 times a day, now to 1 tablet once a day, and now moving even beyond that. There's a discussion, how can you move beyond once a day tablet and try to get a more efficient and find a better balance between the robustness of the regimen and the safety or the tolerability of the drug. That's then been the discussion in the last 5 years in terms of how can we get a better balance on this sense. Because you have improved a lot in terms of potency, but the tolerability and safety of the drug is still a problem that you need to emphasize. This is a message that we can capture from the last guidelines in terms of optimization of treatment. And it's clear now that WHO have developed a lot of studies, a lot of systematic reviews, a lot of meetings discussing these aspects, and these are incorporated in the integrated guidelines last year. And basically, you can say that once-a-daily regimens are better than twice-a-day regimens, not only from the clinical point of view, but also in the programmatic perspective. Fixed dose combinations are preferred for simplification because of the convenience, adherence, more effective procurement, low risk of stockouts, and also in terms of resistance. Efavirenz is clearly superior to nevirapine in long term from the clinical and programmatic perspective, and regarding sequencing, tenofovir has advantage of other nucleosides that we have available today, again, from clinical and programmatic perspectives. Then you have all this rationale clearly explained in the guidelines in terms to justify why WHO have made these choices, and it's still evolving agenda in this sense. Then, thinking in a more broad sense, what is the ideal regimen for the public health approach perspective? Just start to think in a more broad sense, like see the forest instead to see the only trees. And definitely the most important things are safe and effective. You need to find a good balance in this sense. Need to be adjusted not only for the common patients, but also considering about specific populations that have a huge impact in public health, that is the malnourished people, pregnant women, people with co-infections like TB, and very important thing to be addressed here today is how to really harmonize adults in terms of regimens, as you have a lot of challenge when you see the way that the management of these two populations has been done in many countries. And thinking in a programmatic perspective should be affordable in a wide range of countries. Then the issue around patents and the issue of regulatory status are very important components that sometimes is neglected in many discussions. Then this discussion today, you probably open some possibilities of future options for first-line therapy, knowing that the starting point of our discussions today is the tenofovir efavirenz that is clearly probably what is most adequate for the majority of places, consider the current knowledge and in terms of this balance between availability, efficacy, tolerability. But other alternatives are emerging now in the horizon. You need to consider maybe tenofovir low-dose efavirenz. Should you start to think to bring dolutegravir to first line combined with tenofovir FTC? What about the prodrug of tenofovir, the new one, the TAF, 3TC with dolutegravir? Are all options that has been put in discussion. There are some studies ongoing. But again, what is that the trade-offs in this discussion in a public health perspective, in a population perspective, not only individual level? Then what kind of data or information that we need in order to use these treatments in a more widely way, in a more sustainable way? Then there are a lot of trials ongoing now trying to really prove the safety around these drugs. It's just a list of things, some of them will be discussed here, but the ENCORE trial was a critical trial in terms of dose optimization of efavirenz. Stefan certainly makes some reference on this. You have some studies around the use of atazanavir, ritonavir, or even other drugs using lower doses too. You have the issues around the toxicity or how to improve tolerability of some combinations like PIs and tenofovir. That's despite not to be the preferred approach. In second line in countries is very common, as we have a lot of people use the AZT in the first line in the past. And of course there are issues around D4D that we already discussed in the past. It's just historical process. How important was this in terms to really evaluate the safety of the drugs in long term? I just address a little about the tenofovir story, as there is nobody talking deep about this today. There is a lot of discussion around this recent topic because tenofovir optimization, particularly use of PIs, has been a question, and now with the availability of some integrated inhibitors that are also boosted, it's becoming clear that there are some issues to discuss, particularly if you need to reduce the dose of tenofovir or use a new prodrug that can be more safely used in this case. Just to remind people that tenofovir clearly, a lot of studies showing that there is a trend to be more toxic when you use it with boosted PIs and nalbuphine cobicistat because of the boosted effect on tenofovir that increase the levels in the body. But that was not occurring with efavirenz, that apparently don't interfere with that. But the problem that the majority of studies today has been done with this is really trying to reduce the levels or use TAF, a TAF drug, but they are not reducing the dose of the common, the standard tenofovir, the TDF. That's why this discussion is very important now, because basically there are not good studies of good comparisons of the TAF low dose and tenofovir normal dose. That I think is not a very fair combination in terms of comparison. There's some bias in this analysis that you need really to think how to fix this. Then is one of the areas that need more study to understand exactly what's the dose that can be used of tenofovir. If you need to use TAF, or if you can use a lower dose of tenofovir instead, that can be more simple, then it is that you need to see. We also need to check what's the real advantage to use TAF or tenofovir when used with efavirenz or dolutegravir. It is a clear study that is needed, because the comparisons today has been only in the context of other combinations. That's not necessarily the ones that we have in public perspective. And of course, a lot of information on drug interactions is still unknown. Just to emphasize that for this new option that we have discussed here, particularly for specific groups like pregnant women and tuberculosis, certainly the data is very, very, very scarce. And studies in this area is really needed now. And even for the new drugs, as listed here in red, there are some drug interactions, important drug interactions that need to be emphasized, like the use of metal ions in dolutegravir, or in terms of the effect of food in ripivirine. Now, the important aspect that is cross-cutting in all discussions of these drugs is about the use of fixed-dose combinations. Despite the clear evidence of the benefits of fixed-dose combination, this has been challenging in many countries because the cost of the fixed-dose combination sometimes is higher than the cost of the separate tablets. As an issue that has been addressed in some discussions, but basically, as you can see some examples here, sometimes the cost really can be a problem when you have a single tablet costing sometimes 10 times more than the separate tablets in some countries. Then it can be really problematic. And it's really linked to the issues around patents that I think should be emphasized, because sometimes you have the issue of patents expiring for the separate tablets, but when you have the fixed-dose combinations, they have a kind of a renewal of this patent process in order to really have this process even longer, going until 2029, 2030. Then it's an issue that should be addressed. That's just about science, but how you manage this regulatory process to unlock this problem in many places. Then in summary, WHO really what he wants in terms of or expect from the innovation in the treatment and drugs for the next series of guidelines for these and these guidelines now and the future ones is in terms of low dose of strategic drugs like efavirenz, tenofovir, and PIs, if proved safe and effective. The fixed dose combinations for second and third line is also a target that we need to try to get it in order to simplify this approach. In terms of pediatric treatment, the use of pellets and also the drugs like the 4-in-1 FTC for children, in how to integrate inhibitors for both first and second line, how this should be addressed, and important issues about how to improve the PI component of our second line regimens. What's the real, how can we get darunavir as a boost fixed dose combination that can simplify the treatment for second and maybe third line. However, we have a lot of areas that still open in terms of information. This kind of summary table that just to emphasize that for some of the aspects clearly have a good signal, but for many areas it still needs some studies. This is just to emphasize that you have some issues that can take 1-2 years, but for others you can even take more time in order to get this information. Then you need really to pay attention to this agenda and try to set a process to accelerate and really identify it in a very smart way. Then, as put before, this drug optimization process is an ongoing process. It's still moving. You have specific meetings planned now for 2015 and 2016 in order to really try to address these questions. You have some partners here that are involved with us in this. You have other initiatives starting now. And I'm quite sure that the same approach will be used for the hepatitis process. A similar model will be used in this case. Hepatitis, of course, have their own particularities, their own identities, but definitely a similar agenda. And I'm quite sure that you're going to address some way the main challenge and main opportunities that exist today in the age of treatment for hepatitis, but having some inspiration in what HIV is doing. Okay, thank you very much.
The way we would like to do this is that we want to just allow for any clarifying questions. It could be 1 or 2 or 3 max, and we'll see how it plays out with time. And after the 5 presentations on HIV, we would have a larger discussion block. So if there is any questions to Marco at this point, please just say who you are when you raise the question.
More of a question to the whole group. Paul DeMarco, Chai, will you be sharing these slides?
I think from the perspective of WHO, we can share the slides as PDF, and for those who prepared slides, and we would have to ask the speakers, and it'll be up to those speakers, but I would imagine yes.
Is that the only question? Okay. Any other questions? Please, Ben.
Good morning, Ben Plumley from Pangaea, and
is that okay without mic, or?
I've got a fairly booming voice, so...
Do we have a sort of a mobile mic, except the one that I have?
It's like comedy sketch, isn't it? So Ben Plumley from Pangaea, just a question. First of all, brilliant presentation. Thank you so much to set out exactly what's happening, and really appreciated that you've organised this and we're here. A number of us obviously have bits and pieces that are a part of the overall agenda, and I just wondered if, Marco, you could say a little bit more about the CADO 3 that you're planning, because obviously Pangaea and other groups are thinking of something a little similar, and is there a way for us to sort of pool our resources rather than duplicate? So. CADO 3, what is CADO 3?
Well, I think that just for people who are not aware of this specific abbreviation, this is a process that started in 2010, the Conference on Antiretroviral Drug Optimization, that Ben was part of this. Charlie is not here today, but Dave, Charlie, a lot of people working together on this. And the idea is to maintain, to try to really organize the agenda in terms of drug optimization as one agenda. The idea of WHO is try to use this leading process in terms to really get all these initiatives in one, avoid some duplication and avoid the discussions in terms of have sometimes conflicting work on this sense. We're trying to work on this treatment 2.0 initiative 2 years ago. Then the idea on the CADO 3 is really trying to continue the agenda, some way addressing these issues that are not just about science, but how can we unlock specific issues linked to the regulatory processes, how to really have the answer for specific questions related to implementation of this strategy. We understand also why some apparently simply very logical processes are not being implemented as expected. Then it's not just to check the science, but how to see a little how can operationalize it better. And definitely we need to really have all these people together in order to really understand and continue the project that we started in 2010.
So on CADO 3, clearly this is not just a WHO meeting, as hasn't been CADO 2 and CADO 1. We want to discuss with those who were engaged in previous meetings how we move forward. It's clearly should be a shared agenda. We have 2 more, Elaine and Chewy.
just wanted to know what metal ions were.
It's Andrews Hill's language. It's pharmacologist people, you know. I think it's more about these drugs that like anti-acid drugs, it's like that. No, but they use metal because the metal is the point of these anti-acids, like for have burning like that.
Do you have a very clarifying question?
Yes. Thank you. I just wanted to really raise the issue of children in this meeting, and you brushed over the pellets versus syrup and also the 4-in-1. I think we have some anxiety around speed and to which we can get some of these products for children, so it would be nice for you to just highlight where things are.
And we have a separate presentation that Elaine will make on that chair, so you will have to hang in for a while. With that, if there are no other burning questions, you seem like a person with a strong voice.
Okay. Yes. Tripp Gulick from New York. Marco, it seems obvious that lower doses of antiretrovirals would be cheaper, but sometimes people say that the relationship is not always true, particularly in resource-rich and even middle-income countries. So could you comment on that?
Yeah, well, I can start by sure that they, for example, can give the best. The issue is, of course, it's not linear. So you cut by half in terms of the dose, not necessarily you cut the cost by half. Sometimes it's not really the most important issue involved. No? That's why the discussion on dose optimization from WHO perspective is not so focused on the cost reduction, but mainly try to get a better balance between the issue of tolerability, safety, and maintain the robustness of the scheme. But of course, it's a plus that should be considered. I'm not sure if Dave like to, I'm not sure if you address it in your presentation, or like to make any comment on this specific issue about the impact of chemistry in terms of the cost reduction.
We will come back to that question in a broader discussion. I'm afraid we won't have time to discuss it through now. Any other clarifying question?
No, it's not a question, it's a statement. Can I shout, or is that it, or do you want me to have the... It's just about CADO 3.
This is just a recommendation to WHO and anybody else that's going to be organising CADO 3. We've sat in a lot of meetings and we've discovered the standard of care. So we've all decided that efavirenz plus 3TC plus TDF is the best regimen at the moment. And then we've sat in a lot of meetings and decided that a kind of variation with dolutegravir is going to be a really good idea. So I think it would be very bad if we sat in another meeting and discovered standard of care and then decided that dolutegravir-based first line would be a good idea. So perhaps the next meeting should be actually about getting the research to kind of inform the data to make the guidelines change so that people can actually benefit from those discussions, because we have a sort of pipeline of meetings at the moment.
Yes, there's a lot of meetings, but I think that would be certainly a strong element of the CADO 3. Marco, anything you want to say in response to that? Makes perfect sense. Okay, so we will possibly come back to CADO 3 if we need to have more discussion on that and other meetings that might relate to that. Just to bring it all in possibly some sequential ordered conversations that we have. But I would like to introduce the second speaker, and that is Stefano Vella Dr. Stefano Vella from the Istituto Superiore di Sanità in Rome, and I think most everybody in the room probably knows Stefano. Stefano has also been the chair of the adult guideline group for the 2013 guidelines. And Stefano will talk about a topic that I think has been already widely discussed, but what do we need to know about low-dose efavirenz?
Thank you very much, first, for inviting me. Second, we always need to do disclosure, I think, at the beginning. I have just one dramatic disclosure. I'm a friend of Sean Mellor's, that is here. No, not Sean, sorry. Let's go to low-dose efavirenz. First of all, I want to say efavirenz is a great drug. I mean, I think that's a starting point. I think it's important that we say this. And I really think that there's been a lot of reasons why this was chosen in the guidelines. The first is efficacy. Of course, it's still one of the preferred first-line regimens throughout international guidelines. So that's efficacy. So it's a great drug. We try to globally align the standard of care, and that's also important. Of course, if you have a single preferred regimen, that's better for procurement. It works throughout these two situations, and the risk-benefit ratio was analyzed, and we say, okay, let's go with PMTCT with efavirenz despite some issues regarding teratogenicity, and of course, the guidelines were planned also to harmonize throughout all adult populations, and that's different populations. That's where the guiding, some of the guiding principles for efavirenz being there at 600 as, and I really think it's a great drug because the successes we have been seeing over the years would not maybe have been reached without having this drug. All this said, of course there are some problems with efavirenz, mainly the CNS toxicity, but not only CNS, we had reports, but mainly this is the major disadvantage of efavirenz versus nevarapine that has other issues. Now, someone is thinking about lowering the dose of efavirenz. There are some potential advantages in terms of mainly the toxicity and the cost, but I would stay with what Trip Gulli said. I mean, of course, the milligrams is not the main reason of pricing. I mean, packaging may be more problematic than, or more costly than reducing just the milligrams in a formulation. And toxicity is the main, actually, issue, the reason for discontinuation. There are actually potential disadvantages in terms of efficacy. We'll go a little lower in terms of trough levels. I mean, someone already said the PK interactions, the pharmacogenetics. You know that some populations in Africa have different haplotype that metabolize efavirenz in different ways, and also what I see is that if we go with 400, then there should be a regulatory filing, even for production, even from generic production. They need even for just suggesting this in the guidelines. There should be a regulatory approval. That's one problem. Now let's go to the anchor trial. This is the more solid data we have on dose reduction. Actually, the basis is pharmacological. At the time of the MP 266, you remember the old efavirenz name, some data already showed that 200 milligrams were effective. They had the same effectiveness, or efficacy, let's say, with respect to the higher doses. And you know that in pharmacology, I'm not a pharmacology, when you generally go with a higher dose if it's equally tolerable. But those are the data. You see, it worked fine. The 200, the 400, and the 600 at that time. This is, remember, that's CROI 1998. These are the results of the ANCHOR 1 trial, which compared the two doses. You see that actually the results were even slightly better for the 400 milligrams. That may be due to treatment discontinuations, I don't know, but here we have our friend that knows better than me. So in terms of less than 50, it worked. And also in terms of adverse events, you looked at there has been differences. It's significant, statistically significant. Not dramatically different, but look at the number of patients stopping drugs due to adverse events is really 1.9 versus 5.8 with the 400. So that's positive. And this is the kind of reduced adverse events And you see that, of course, CNS reduction was there, and rash reduction and gastrointestinal, mainly. So from a tolerability point of view, this trial was a success, saying that these toxicities are reduced. So the conclusions, again, from the paper presented in Kuala Lumpur, where that was not 400 milligrams was not non-inferior to 600. There is an evidence of reduced efavirenz-related side effects with lower doses, and so 400 milligrams could be considered, should be considered. Let me go back to the potential disadvantages that we may have because we lack some data. So this is, I think, is a matter for later on or for this afternoon. Which additional trials are needed to be sure we will not lose the harmonization advantage throughout population. So if we need to adjust or to change, or let's say, if efavirenz doesn't work the same, efavirenz low dose doesn't work the same with TB, in PMTCT, then we will have the issue of changing something or switch to another drug for these conditions. That would not be in line with our philosophy. So, particularly pregnancy and rifampin interactions and other PK studies are needed. I don't know which ones, but you may suggest this. And I have a final key question, which is a little naive, but I think it will be addressed by others. Shall we necessarily continue to stick with efavirenz, which is, again, as I said, a very good drug, or shall we try to switch to available better drugs or even develop brand new first lines instead of perfecting what we have? Should we switch to something new? And there is a list of things that are available in high-income countries. Others are coming. And in a very recent commentary I wrote in the Lancet HIV, I said, I remember what Joop Lange was saying, first line shall not fail. That was like 15 years ago, he said that. And I was just anticipating that I'm scared that if we don't innovate, we may have a problem in a few years. Now it's very good. Everything is fine. Mortality is going down. But we need to think ahead in 10 years. And without monitoring, with some fragility of our first line drugs and the small number of second lines, we may have some problems in the future. I'm not saying today, but we need to think ahead. Thank you.
I think in the same light that we had a few questions from Marco, are there any few clarifying questions, maybe one, two? We have a roving mic now, so
I'm aware it's Paul DeMonic from CHI. I'm aware that there are a number of people concerned about resistance to efavirenz, and it's sort of a sparse set of studies. I'd like to hear some thoughts on if we lower the dose, what does that do?
And we also have, just so people are aware, we have Sean Emery, who's in our audience, who ran the ENCORE trial, so we have the actual, we could hear from him as well if we'd like to.
I just want to, sorry, is this good? Okay. I just want to say, I think maybe some others from the ACTG or from the US make comments on clinical researchers. Sorry, is that it? I think maybe some other clinical researchers may want to comment, some ACTG people, perhaps, and US researchers. But I think in the US it would be unacceptable from my point of view. I'm familiar with the PK. I think you're going to waste your resources. That's my feeling. When you can spend your resources on better regimens, I think you're going to find serious problems with the PK at 400. You didn't look at under 50. And interpatient variability, and the Cmin when you do the 400 is at the edge a bit. So I just wanted to mention that. Maybe some others want to comment on that. And of course, that is related to resistance. And I think you're playing with fire, frankly. And in the US, it wouldn't be very acceptable, I don't think. That's my feeling.
So we'll let Sean make a few comments and then maybe Stefano add.
Is that okay?
Yeah.
So resistance was a key theme of the Encore 1 study. So we had 630 participants there or thereabouts, followed for a period of 2 years. They were treatment naive coming into the trial with reasonably high virus titers at entry. So we were able to sample and characterize point mutations for the participant population at entry, and we were subsequently able to pick up individuals with defined viremia during follow-up across the 2 years and compare and contrast between the randomized treatment arms of the trial. So it's certainly the case at baseline there was a small proportion of individuals whose virus had point mutations that would normally align with reduced sensitivity to efavirenz. There was no difference in distribution between the treatment arms, and there was no difference in outcomes for those individuals in each treatment arm. In fact, quite surprisingly, but backed up by the literature when we looked, virus with point mutations normally associated with resistance at quite high levels to efavirenz, those individuals were successfully suppressed for 2 years of follow-up. So I don't think there's a complete understanding in quite the way that you'd suggested, Jules. So the second thing is there was no difference between treatment arms for emergent treatment resistance during follow-up. And I take the point about the PK. We did an awful lot of pharmacokinetic sampling in a PK-rich population in Encore 1, and we did a lot of PK sparse. I've got the shakes this morning. I think I've OD'd on coffee. And the net effect of that really in terms of what the treatment group comparisons were really is that you can't reliably use pharmacokinetic levels or parameters to understand the efficacy of 400 versus 600. And there's something fundamentally not quite right about the somewhat arbitrarily defined threshold of essentially a milligram per litre of efavirenz defining what is the goal treatment level for efavirenz. It's just not quite right. And I think it's foolish in light of those new data to assume that you can reliably use that as a means of assessing the impact of doing other things or understanding the impact of lower dose efavirenz in defined populations. There's something incomplete about that previously defined threshold of treatment goal for certainly efficacy. I'm not sure about the issue of toxicity. And so I do understand the need for those things to be discussed. We've now got data that were presented, in fact, at the Glasgow meeting to 96 weeks on this cohort of 630. The week 96 data are entirely consistent with the week 48 observation. There is no difference in efficacy between the two treatment arms. We've done extensive resistance testing. It doesn't matter, and there's no difference between treatment arms on the basis of those two randomized comparisons. And the pharmacokinetics is not consistent with there being something that one would normally be concerned about. And all those data are in the public domain, so I'd really like to see the slides updated to reflect that as much as is possible, because obviously in an audience like this, publicly available data not being put up doesn't help the debate, but that's as much as I'd like to say.
Okay, thank you. So clearly this is a topic that is going to be debated further. Since we're running behind, I'm going to stop the questions there because we know there's going to be lots of them. And we're going to have an opportunity to discuss more in our 30-minute discussion about ARV optimization. And please write your questions down and keep them with you. And also to know that WHO is going to be debating this in our next set of guidelines. So there is no recommendation one way or another at this point in time, and this debate helps us and helps form some of the thinking that would be brought into the ARV guideline decision-making processes. So next I'd like to introduce Dr. Francois Venter, who's a professor at the Reproductive Health and HIV Institute and University of Witwatersrand, who's going to talk to us about integrase inhibitors.
Thanks for the invitation, everybody. Just so you can see the tendrils pharma has in my life. Most of my funding actually comes from PEPFAR and from the Gates Foundation, but just so you can see if there's any conflict of interest. I'm going to just firstly just abuse my position here a little, is just to plead with, particularly with this group, because you often giving these kind of talks for a little bit more sensitivity when you are putting up guidelines. It may come as a shock to you, but actually most of the guidelines here, the guidelines for the South African Department of Health actually cover far more people than all these guidelines combined. And I do plead with you that when you start putting these guidelines and recommendations, next I see Mark has managed to slip Brazil in there, it would be nice to just acknowledge the fact that there are actually regional guidelines, and I'm sure the Asians feel the same way, that need to be acknowledged when you start doing these comparators between when to start decisions and all the rest of it. And that's just something that's a bit of a bugbear, certainly among the South Africans, that these things get routinely put up without acknowledging the fact that there are actually, you know, these are your own incestuous guidelines, we have our own incestuous guidelines, we'd like our incestuous guidelines to at least be acknowledged. As we know, we've got this amazing situation in 2013 where we got the harmonization processes right, and this group were, most of the people in this room were involved in that process. We have got a situation where we've got this harmonization. It's not total, there's problems with the pediatrics, it is sometimes a little bit overcalled. Even at the time that this harmonization, so-called harmonization happened, within developed countries, people had moved away from efavirenz. Already I'm told that drugs like Complera and Stribald were being used far more commonly than the Atripla and various generics in place of this in developed countries, mainly because of the side effects around efavirenz. And I do think that we're at quite a difficult sort of juncture at the moment. Was this just a brief harmonization event? Are we going to have to come to terms with the fact that we're going to have to start separating again and start looking at different regimens in different places and all the rest? I'm not quite clear on that yet. I think it's probably a little bit early to call. Stefan, I know Kenny's got slides on this. Efavirenz is now routinely substituted in the developed world, and due to the side effects. These the CNS side effects, there's been a little bit of a spate of inconsistent data on suicide, but certainly in South Africa we've seen quite a lot of hepatitis, including a few cases of patients requiring liver transplants, both in Cape Town and Johannesburg, where it's not quite clear to us whether it's just simply the fact that we have 3 million people on treatment, and it's just the fact that any rare side effect is going to pitch up there, or whether it's actually it's something that's been underreported in our certainly in developed world context. But certainly Stefan has talked about all the other problems around it. I think the reason we put in, I think it's very important to be clear, we're not putting it up for any other, I don't think, for any other integrase inhibitor. I think dolutegravir is the drug that we're actually talking here as the game changer. I'll talk about the others in a moment. So why? They're incredibly well tolerated and they're very effective in both dolutegravir and dolutegravir, which have been compared head-to-head with both alternative first-line drugs, darunavir and efavirenz. They perform better. I think it's quite clear that it's not a huge difference, but it's a significant difference. So what about the old dolutegravir, a drug which I've got a bit of a soft spot for because it's been very, very well studied. I'm told it can be used in pediatrics above 4 weeks, which means that there's the harmonization of at least if not dose, at least in terms of name. We certainly are starting to use it increasingly in post-exposure prophylaxis, but it's remained, even with significant price reductions, it remains relatively expensive. It has a high milligram dosage, so it's unclear about how much that cost is going to come down. It's dosed at twice daily, although there are various studies looking at addressing that. And its use in the developing world at the moment is largely been confined to third line. In places like Zambia and South Africa, where there's a significant number of patients on third line, that's very much a part of what we use. I don't really think this is likely to change in the next in a couple of years. Unless there seem to be too many hurdles to cross around the TB issue, around the cost issue, around the co-formulation issue. If it does, that's great, but I must say that this was not the reason. I don't think most people are hopeful that this is going to come in and replace efavirenz. The same for alpha-tecovir, the drug around that's called Stribald or Quad. It's interesting, when I've had discussions with the Gilead people, they are busy licensing it in South Africa and are quite aggressively marketing it and hopefully going to be pricing it in a way that it probably would be available. In the sort of public health domain, I'm not sure whether that's going to have any traction. And you'll see the last slide there is, I think certainly in places like middle-income countries, there might be a role in the private sector or possibly in specific groups of patients who've got toxicity. But again, the issues around its cost and its issues around pregnancy and TB are unresolved. So again, in the next few years, I don't see this as having a major role. It's got a lot of potential for drug interactions, And the creatinine clearance issue I'll get to in a moment, but has been acknowledged as something that messes a little bit with public health programs. But the one we're really interested in is dolutegravir. It's low milligram dosage. The Chai people tell me it's relatively easy and cheap to manufacture. It's already co-formulated with bacavir, which was recently registered in the US. Its resistance profile is very compelling. I still haven't heard of any first-line failures with the specific dolutegravir mutation. Again, it has a slight creatinine clearance issue. The TB is a problem, but I hear that the study is looking at double dosing it, have actually commenced. So hopefully we'll have that data before, in the very near future, so we can make that. And it sits in pregnancy category B. Something, and just to acknowledge the pipeline report that Polly puts out, which is an amazing resource for those of us who don't sit in these meetings as often as we'd like to, is that she has focused that the studies in dolutegravir were largely done in men. So again, whether that's important or not, we're doing a huge, at least half the people who are going to be receiving it in my environment are women. So what about the creatinine clearance? I'm not sure how important this is. It's always raised as an issue. A lot of the tenofovir toxicity that is reported in my environment is largely anecdotal, and in the context of patients severely ill who've got other reasons for renal dysfunction. This little, not always spoken about, observational study by Lloyd Mulenga in Zambia, which demonstrated that even when people were put on tenofovir with significant creatinine problems, most of the patients actually didn't get worse. In fact, in the more severe forms, they actually seem to get slightly better. So I'm not sure about, if you have a baseline creatinine clearance that's normal, how much we should be taking the creatinine clearance issue seriously in terms of these two drugs. But there is a cost, and I think that efavirenz, as we know, is a far from perfect drug, and the problems come into the helm. But we are going to have to, if we do move to dolutegravir, move millions and millions of patients across. It's a massive manufacturing undertaking. It's a massive logistical issue. The pharmacies and things are going to have. So it's not a decision to be taken lightly. This is, we hear from the generic manufacturers alone how much they can complain when they get told that the drugs are changed every other year, and they have to tool up for this. We moved all our patients from D40 to tenofovir, and it was not a pretty process. It worked, and thank goodness it's testament to how safe I think tenofovir is. But this is going to be a big deal. What also happens is that moving from efavirenz to dolutegravir I don't think is a big deal. However, when you have a disrupted supply where you move backwards and forwards, it is a big deal. If you go from dolutegravir to efavirenz, which may well happen during the transition period, that is going to be something that is a problem. I'm not sure whether we're going to need viral load monitoring to move across. Hopefully dolutegravir will trust its resistance barrier enough to move those few patients who will have a detectable viral load across without having an issue. There's lots, you're going to hear lots and lots of, we need more training, we need lots of training to do the transition. I can tell you that from our perspective, moving to D40 to tenofovir, we had some training at the diddly squat in terms of making any, I think we're just going to move across en masse, and we're going to need to make that choice immediately. It does mean that there's going to be harmonization issues. We do programs across borders. There are often truckers and sex workers who are moving across, and it's been good having the harmonized guidelines because we've been able to find tenofovir-based regimens in almost every country in Africa now. So if we lost that, say for instance South Africa went to dolutegravir and Zimbabwe stayed with efavirenz, that is a negative. And certainly in South Africa, where there's a big issue around the private and the public sector, we've tried to harmonize the guidelines because patients move in and out of the private and the public sector almost seamlessly, and we had a good time having a harmonized guideline. There's limited data still on dolutegravir, and as Polly pointed out to me this morning, and particularly in pediatrics, and we still need the results of the TB studies and and studies done in the field. And then what happens if what happens if a new side effect crops up that we didn't anticipate? What happens if it doesn't work in TB? What happens if there's a flag in pregnancy? These things all happen in drug development. So what happens if it happens halfway through us rolling out dolutegravir across the African continent or Asia or wherever else? Are we going to be able to pull back and revert? So these are not small decisions. I don't have a very fixed view on it, but it's a big decision. What about in second line? I think it's clearer there is that it's very appealing. You can move across. There's no cross resistance. But I think the funny thing is that Ernest suggests that all you need is one good working protease inhibitor. It doesn't really matter what the nucleoside or what the backbone is. So do we really need to dodge dolutegravir in second line? Or could we just recycle those nukes and see what happens? We've had these, what seems like eternally planned low-dose darunavir dolutegravir study discussions, and finally it seems like these studies are finally being done. But we probably need the results from those studies before we can make a call on second line, and that's going to be at least 2 or 3 years' time. Is dolutegravir the new PI? I think that's an interesting thing to think about. Can we just cycle across and use it in second line? And again, we're going to need the studies to actually demonstrate that. And if somebody's brave enough to just use it and to replace the PI and recycle the nukes, who knows what we might be able to find out there. So, are there alternatives from switching efavirenz to dolutegravir? I think there are. We could go with the low-dose efavirenz as Stefan has talked about. Something that's not spoken about is rilpivirine, a very, very cheap, very co-formulated drug that is available in many of the countries already at a very competitive cost. There's some food issues around it. It can't be dosed with TB, but theoretically you could. You could even start patients on low-dose efavirenz. The ones that didn't tolerate could move across to rilpivirine. So while dolutegravir is very enticing, there are alternatives. My view is that we still need some more data on dolutegravir, and particularly field data in the African setting, before we can just roll it out willy-nilly and change things. So my recommendations are that we need to prepare for it in first line. I'm not convinced that we can move it immediately there in the next year or two, but it seems like this is the drug that's coming, and that certainly in first line I think that we should be thinking about what are the issues in TB, in women, in pregnancy that are required, and start pushing that research agenda ahead so we can prepare and let the generic companies know that they're going to be needed to change their manufacturing capacity. Thanks very much.
So I think, again, 1 or 2 clarifying questions, and we have in the back.
Can I just be reminded, Francois, about the interaction between efavirenz and dolutegravir? Because if you're going to switch a whole load of people on, they'll be on an enzyme inducer, and then you suddenly have to go on another drug. It might be that the 2 levels overlap like they do with rilpivirine. But the second thing that people haven't spoken about is in the clinical trial, the open-label 96-week clinical trial of dolutegravir versus darunavir. At 2 years, between about 15 and 18% of people weren't on the drug they were prescribed at the beginning. That's in a clinical trial, and that sort of slightly concerns me about about this whole rush at the moment towards let's just switch over tomorrow. Because if there are issues about why people can't retain in care on these therapies, then there's a problem that we need to try and do some research about. What about the efavirenz and
No, I guess you're right. I mean, I think these are just some of the things we're going to need to tackle. And I must say, from my perspective, I'm always happier when a couple of 100,000 Europeans and Americans have had the drug tested on them before it comes to us. You guys kind of sort out the issues.
I think there was one other question in the back. Yeah?
I'll try to speak loudly. Francois, my name is Anil from Mylan, a generic ARV manufacturer. The question I have actually is, thus far this morning, and I think there's been an ongoing debate about a world in which everyone is on dolutegravir for first line or efavirenz. And actually, I wonder if there's another answer. And it's a question. We don't have a perspective on this, but we are one of the manufacturers trying to prepare for the future. Is it possible that dolutegravir would be in first line, but patients on efavirenz would remain, and dolutegravir would be used for treatment naive, and so you would essentially have 2 large cohorts, especially as we look to going from 12 million people on treatment to 30 million people on treatment? Could you have large volumes of patients on both products until, for another reason, there's failure on efavirenz, whether at 600 or 400, and then a move to an alternative regimen, whether a dolutegravir regimen or a second-line regimen? So it's just a question of, is the whole world have to move to one or the other, or is it possible that we'll have both?
So Ideal actually wants to move to next. It's a second best option. Where we had D14 tenofovir, everyone just moved to tenofovir.
Yeah.
No carefully constructed thing. It was immediately apparent that the one would be available in the pharmacy. So I think, and South Africa is relatively sophisticated. I think in a situation where you have 2 or 3 regimens is suboptimal. So I think your idea is great. Whether it's practically going to work that way, I doubt it, to be honest.
Yep. If I can add, yes, but there is a difference between D40 and so efavirenz, as I said, is a great drug. And let me just remember the times of the guidelines. Remember that we had the grade system there. So I think that the focus today and this afternoon should be on research, because definitely we need data on. We cannot just say to our guidelines review committee, say, yeah, we know we changed, and so we need solid data behind whatever we suggest. And so research is needed.
Okay, very good. I think if you have other questions, I think there's one more. No, Charles, if you'd like a question, please go ahead. All right. I think I'll hand over to Godfrey, who will introduce our next speaker.
And that is Kenley Sikwese from AfroCup, director of the AfroCup network. I don't see him. Oh yeah, he's there. When Kenley walks up, obviously the voice on the ground and the voice of the patients is a very important one. And obviously the participation also of civil society networks and those people who represent the voice on the ground has been important for us in our guideline development efforts. And Kenley has been a member of the guideline group in the 2013 guideline as well. And I think collectively a lot has been invested in treatment preparedness of those who are on treatment, start treatment, etc., etc. And I think what Kenley is going to show us is how there has been a progressive sophistication of those patients in their demands. Kenley, please.
Thank you, Godfrey, and thank you for inviting a community voice from Africa. I do have a conflict to declare, and that is that, of course, I'm interested in everything and virtually are affected by everything that every conflict has to offer. So my declaration is that I do have conflict. I think when we think about thinking back at the evolution of highly active antiretrovirals, we've seen a progression, and I think it's been very, very well documented by the previous speakers. We had D4Ts, DDIs, and I'm sorry, I'm worried about this. We've seen the progression from side effects, improved toxicities and improving ease of adherence, drug resistance, and so on. And of course, we see second lines with boosted protease inhibitors, and of course now we're talking about integrase inhibitors. And so we're seeing a large evolution, and a great evolution and innovation for better better drugs for treating HIV. And it was exciting when I sat through the 2013 guidelines that we were finally going to be treating people earlier. And I think some of the politics behind that were absolutely quite emotive, but we got there in the end. But if you look at the recommended drugs, of course TDF being efavirenz-based regimens being at the top of that. These are the three regimens that were recommended: AZT-based and abacavir-based. If you come to a clinic like where I go, or maybe Charles's clinic in Zambia, you find that these drugs are still very available. With the most people, of course, on TDF-based regimens, but a sizable number on abacavir, a sizable number on AZT, and so on, depending on whichever they were initiated on. And so I think when we speak about drug regimens and optimization in an African setting, people still use these options and still have this wide array of drugs that they can choose. I think when we go to first, second line, and third line, that's where it gets a little bit complicated. However, I want to start with that point, because it's important that when we talk about TDF, the harmonization of TDF-based regimen was great, but even to this day, countries are still managing multiple drugs in their supply, in a purchase and supply of ARVs. I think, of course, all those studies, I suppose we don't need to talk about them, they're starting, but the other thing I also want to talk about is, if you look at, I think, in addition to what Francois said, is if you look at the changing environment of guidelines with initiation of antiretroviral therapy, is you're seeing all these countries that are changing to, maybe test and treat approaches, or in the north, or if you may be in the south like Brazil. Of course, the British always want to be different, so we can forgive them. But the choice to be able to start when you want and how you want your treatment to be managed is a very liberating, thing, even for a person living with HIV. But much more important, it also just takes away a lot of the complications that countries have to go through in managing patients or people living with HIV. One day they show up with a 600 CD4 count, and 6 months later they are 250 or 300, and maybe even with an AIDS-defining illness. I think, for me, the critical thing that we will be needing to look at is that there will be definitely a need to go to treating all, and that will be really determining what kind of regimens we use in terms of all the safety profiles and the toxicities that people have been talking about. And the clinical benefits, not just to you as carers, but also to me as an individual living with HIV. And so, yes, we do need data. We need, to have drugs that will provide as normal a life expectancy as possible. We have kids now that are beginning to fail on drugs, on ARVs terribly. And how do we try and manage that? And I think, I'll mention something about maybe some of the possible challenges. And of course, some of these ARVs that we are taking right now are better than what we started off with, but they're still not the best. And even though we don't know a little bit about some of the newer drugs like integrase inhibitors that we mentioned, they might be a little bit better. And like Francois says, we're getting to know a little bit more about how, say, dolutegravir affects people, because it's being tested on people in the north, and and that data would definitely help us in managing people living with HIV in the south. But what is really the ideal target product profile? I was part of CADO 1 and 2, and during CADO 2, I was so sure we nailed what would be an ideal target product profile for first line and second line. And I think it was very, very clear in the conversation that we felt that a dolutegravir-based regimen with TAF, when it became available, would be really the way to go. Given their low molecule and low dosage. And so we were very excited, and I'm surprised that we are still talking about what would be an ideal target product profile 3 years later. And we're talking about CADO 3. I'm glad maybe look at other things, but it would be good to revisit what CADO 2 proposed, both for first and second line, with dolutegravir-based regimens and so on. But what we do definitely need to do is really get off the kind of drugs that we're using. I mean, I lost a brother a couple of months ago who was on Calitra because somebody couldn't switch him to something else, like maybe even atazanavir, I don't know, or dolutegravir if it were available. But people are dying unnecessarily because we're really getting really outdated drugs. Efavirenz, great. I think for you people who don't have to take them there, it's a great drug. But for us that have to drink it, trust me, it's a horrible drug. I've been on evaropin now since 2003 because I think I do better with it. I sleep better, and okay, I've finished with AZT and what else? TDF. I'm on abacavir now. But it's still an evaropin. The NRTI that I'm on is in evaropin because I could not stand to take efavirenz. I remember I used to try and break it in half, but even then, it would reduce the impact that it would have on, the CNS impact, but it was still there. The dreams changed from being hit by a train to, being missed by a train. So, and so this is really that reality we really have to think about. So you got to think about not just the safety profile from a chemical point of view, but from an impact that it will have on individuals, and especially with adolescents. Kids are just stopping, as soon as they get to find out that actually they sleep better when they don't take their drugs, they don't take their drugs. And so we really need to think about, are we doing much more harm by trying to maintain the status quo, or by taking a risk And I think Neil probably makes a good point that when we have naive patients, should we be thinking about introducing them to an integrase-based, regimen like dolutegravir? And so we really need, and I know all these answers we still need to find out, but I don't think we should look at some of the codes, some of the people that may need to be researched, such as women and pregnant women and women in general and children, as an inhibiting element, but rather that it would give us a stepwise approach, and we could begin to introduce these drugs, in a limited number of people at a time, and so programs can adapt and change as time goes on, rather than being, until we can treat everybody, we don't do anything. TDF, again, and I'm glad you mentioned a study in Zambia. I was trying to see the renal center, the man running the renal clinic in Zambia. Your numbers of people that are needing renal dialysis are increasing. Is this associated with TDF? He would not speak to me. By failure, by his refusal to speak to me, that said volumes. Now, but what he did say was, look, we're probably diagnosing people with renal failure better, but I couldn't tell you whether it's associated with TDF. But the failure that no real studies are beginning to really trying to answer this question is worrying. In the UK, I remember when my my creatinine issues arose, I was switched immediately. But that doesn't always happen in Zambia, and so we really need to revisit some of these regimens that we still think we should keep. New combinations, yes. I mean, it's beautiful. I mean, I remember when I first heard about dolutegravir, it was virtually superior to to efavirenz, to dorenivir, and so on. Rolutegravir being superior to efavirenz, and so for me, it still speaks to the fact that if we're really trying to keep something that is inferior, we are really trying to have an equitable approach to the way we treat people. People that I know in the North now, all of my friends have actually been changed to an integrase-based inhibitor regimen. People living with HIV, if they're here, if I ask them to put up their hands, almost 90% will have been switched in the last few months. And we know that the prices are dropping. We've been pushing Viv and others to try and put their licenses, negotiate new license, prices through the medicines patent pool, and that's working. So price is no longer a factor, and it's really the way we manage and innovate in our treatment planning. I mean, this is some stuff you're familiar with on the superiority of integrase inhibitors. I think TAF is, nobody's said anything about TAF, and I hope we'll talk a little bit more this evening and when it becomes available. Again, we've managed to reduce the price on that, and as communities with a lot of advocacy and so on. So when it becomes available, the price will be a lot lower. Again, this is all stuff you're familiar with, but I just want to end with the idea that I think Polly mentioned, that CADO 2 came up with some really, really brilliant ideas on how we move forward with treatment in low-income countries and low and middle-income countries. And we should really not throw the baby with the bathwater, and really just look at how tomorrow we can improve the care of people living with HIV in low and middle-income countries. Oops. And I did ask Polly to help me with this, and Benjamin and a couple of others. And thank you very much.
Thank you very much. Stay with us for a moment, Kelly, in case there are any questions. So it's really interesting. While we're all talking about dose reductions of efavirenz, you're telling us to throw it out altogether. Sort of. Any questions to Kelly or any remarks? Please.
I just want to briefly comment. I'm Jules Levin, Executive Director and founder of NATAP, based in the US, and I've had HIV for 25 years. So it was great to hear you, and despite the fact that we're in totally different places in the world, I totally agree with you. I believe efavirenz is not a good drug, and I think patients in the United States, where they have access to everything, a lot of patients do not like efavirenz. I'm totally in agreement with you. And I think oftentimes efavirenz is forced on patients because the doctor thinks it's a great regimen, and it is potent, there's no question about it, and it has great PK. And in studies it looks good, but in the real world, for patients that have issues and anyone who's affected by the CNS effects, which are a lot of people, and a lot of people don't even realize they're affected by the CNS effects until they stop the drug. So I think it's a very problematic drug, and that's why I mentioned investing resources in dose reduction studies concerns me, particularly even though the CNS side effects may be reduced, the CNS side effects are still there. So why even bother dealing with it when perhaps you can move on to better regimens? So I agree with you. Thank you.
Martina?
I think this, thank you very much. And it's so interesting that right now, one of the biggest challenges in keeping people in care is, the loss to follow up are people, or even if they stay in care, they have to put up with they don't know what's happening to them. So they go for prayers, for deliverance, they think they've got demons, or they go to see witch doctors to help them manage their CNS effects and so on. So it is a really challenging, and as I say, as soon as they find out that these things stop when they don't take the RLEs, they stop.
Please.
Yeah, I wanted to ask you a question, which actually I had during the Baverin's presentation as well, which is, how much of treatment failure and switching that we're seeing today is due to discontinuation due to tolerability issues, as opposed to resistance development for patients who are adhering. Based on data we've seen, we see huge rates of attrition due to tolerability issues and not due to resistance development. So any regimen, be it reduced dose efavirenz or dolutegravir, where you see better adherence and easier to take regimens from a tolerability perspective, give you a larger benefit than the concerns about PK failure in a small number of patients who are adhering but have a problem. And I'd love to hear your perspective on that.
Is this for WHO or for Kenley?
Kenley.
Oh, that's too scientific for me. But in a care, I think one of the things I try to do is try and remain grounded in the care mechanism in Africa as much as I can. And yes, you're right. The tolerability issue is showing that people are wanting to change, or at least failing in their treatment because, as I say, and we're seeing this more and more in adolescents, due to the CNS issues.
I could mention that in terms of how we're going to address some of these questions in the ARV guidelines is we've typically done work around toxicity monitoring, loss to follow-up, and we're also doing a piece of work where we're actually looking at some of the qualitative data to look at, are there treatment limiting toxicities, and what are those in terms of the qualitative issues in terms of stopping therapy, as opposed to just, so that would be toxicities, intolerabilities, and to get a better sense of how this is being represented in maybe the non-traditional literature that we usually look at in terms of clinical trials, where it's just categorized as ACTG 1, 2, 3, or 4, etc.
Kenny, I was going to ask you, when you substituted back to nevarapine, did you go back to twice a day, or did you get slow release nevarapine? Because I just wonder whether that really didn't come up in a lot of discussions at the last guidelines, I don't think. But if, in fact, dolutegravir isn't quite there for a mass changing over, which I suspect it might not be, is this something that should be thought about a little bit more? Because I know that whether you're talking about adults or children, there's still a lot of people taking nevarapine.
Well, I live in Africa. Slow release. So, but I'm on a generic.
Well, no, the generic is available. That's what I'm saying, and shouldn't that be a possibility that people who have to change from efavirenz don't get penalised by having to go on to twice daily treatment?
I totally agree with you. I was just really joking. But I take an ordinary environment. It's not a slow release. and I take it once a day. So it's, you know, there's no Kivexa or whatever it's called in America. So I have to take 6 tablets once a day as a fixed dose. So I don't have to take it twice. I don't miss my evening dose. So, you know, I just take the ordinary nevirapine, and it hit me first time. It took about a year to get over the rashes. It took about a year to get over a couple of, you know, whatever nevirapine does to you. But once I settled on it, I have been quite happy. And between efavirenz and nevirapine, I don't think, for me, it's a no-brainer.
One last point.
This is a general comment, Andrew Phillips from UCL. The discussion about potentially moving the sort of unified regimen in the future, it seems to me that it's very important to try and quantify all these, you know, people are talking about, I'm worried about this, or this is bad. I think it's important to do a quantitative analysis which takes into account, I mean, I worry in particular about the process of producing the drugs and enough of the drugs. There's clearly an issue at the moment with the fact that there's not enough buffer supply of drugs in many countries, that people have to come back to clinics every 2 months. That's clearly a huge issue, and we risk damaging, you know, that even more by creating more uncertainty in generic companies in terms of scaling up production to produce enough. So I'm not arguing against it, but I'm just saying I really think it needs to be quantified.
Clearly, I think that's an important issue. Anything you want to say in response to that? Then we have Nikos who comes in, and then we move on.
Very quickly, I mean, I do agree with you, but part of the problem, we had a consultation with generics and originator manufacturers just last month, and I know, working with our governments, the biggest problem seems to be managing our supplies. You know, being able, to do forecasts and so on. I know WHO supports, you know, some of the countries in that respect, but still, if what would really change for me those buffer stocks and the levels at which drugs are made available at the right time, in the right volumes, would be if it were more transparent. That we knew who was buying what, that there were open tenders, who was tendering, who, you know. So if, for instance, a contract is given to Mylan and they fail to produce to meet, you know, their quotas, we should be able to say, right, you know, we should penalize Mylan and go to somebody else, or whatever. But all I'm saying is that it seems to be more a supply chain management, really, rather than, you know, capacities of the various manufacturers.
Nikos, please.
Nikos, that is with the European AIDS Treatment Group and also a member of the Afro Community Advisory Board. I wanted to address this to Francois, because I think that this demand to have randomized clinical trial data for new medicines is, let's say for dolutegravir, is more than what we asked when we decided to choose efavirenz for a few million people who would access it. So I don't think we should demand as much. But one thing that I think is an analysis that we must make is to see the patients' years of people who are on these new medicines and see if there's a signal beyond which I think that we have enough reassurance that when one analyzes the existing clinical trial data, which show better tolerability, better efficacy, that those should be actually true. So if you compare the clinical trial data of efavirenz and dolutegravir, you see the difference, or darunavir. And then if you have sufficient, as I say, and there has to be a threshold above which the things that we have not seen is so minimal, which wouldn't play a huge public health role. And I think that this should be in the guidelines, you know, from the regulatory perspective. You know, the life cycle of a drug is not just the clinical trials data, so it's the pharmacovigilance in the West.
Thank you, Nikos. We move on to our last speaker, and
Great. It's my pleasure to introduce Elaine Abrams, who is Professor of Pediatrics and Epidemiology at the Columbia University, and ICAP, and also a member and co-chair of our clinical ARV guidelines. So thank you, Elaine.
Thanks. Just one comment on the conversation. I can remember at the last guidelines meeting talking with Elliot Reyes, who proclaimed that he had 1,000 patients on efavirenz in his clinic and had never had any problems with anybody stopping because of side effects. So I think we have to keep all of this in some perspective because we made a big change from nevirapine to efavirenz. And now that we have something better on the forecast, I think everybody is running forward, and we probably need to be a little bit measured as we make these decisions. So, but now I'll talk about pediatrics, and you can see all of our woes. Makes the adult treatment look great. We were asked to consider the issue of lining adult and pediatric ART in the context of harmonization. I'll provide a little bit of background, and then we'll talk about this issue of low-dose efavirenz, integrase inhibitors, and TAF, and then some directions for treatment optimization in children and adolescents. So in general, we're way behind the adult population when it comes to treatments for children. The timeline for development of new drugs is much longer. We have far fewer drug options and pretty limited age indications with, unfortunately, a variety often of unfavorable formulations. And there are particular adherence challenges in addition to the ones that adults face for infants and for adolescents. Kenley, I don't think it's just the efavirenz that's the issue for adolescents stopping their drugs. I think it's something about that period of psychosis called adolescence. There are also procurement challenges due to the difficulty in forecasting and storage requirements for some formulations, particularly liquids. And I think in general, though we've seen some improvements, manufacturers are often less invested in producing pediatric products. And kids are different. For those of you who aren't familiar with all the nuances, this is just a list of some of the differences. Natural history of HIV infection in children is different. Higher mortality and viral load in the youngest kids. There's a pretty profound impact on neurodevelopment and growth. And then when we're thinking about children, we're really talking about a whole spectrum from 0 to 15 or 18. With growth and puberty and the need to change the dose or adjust the dose as the body grows and changes. Drug metabolism is often different from adults and can be very affected by different factors, including genetic polymorphisms. We've had a hell of a time trying to get a dose for efavirenz in children who are less than 3 years old, particularly for this reason. Infants and young children are also affected by selection of drug resistance as a result of PMT-CT exposure, and a number of the key childhood comorbidities might impact drug use, tolerance, and toxicity. So we've had to tailor treatment strategies for pediatric populations, which are often not entirely consistent with or harmonized with what's being done in adult populations. For instance, we recommend PI for first line for infants, and the same approach has been suggested for adolescents as a more forgiving approach to the erratic adherence we often see in adolescents. One of the guideline recommended approaches, because we currently suggest using lopinavir in infants, is a switch strategy to efavirenz in virally suppressed young children. For examining simplification, possibly using darunavir and dolutegravir, I think that's come up with adults as a possibility. And some treatment interruption strategies have been studied in children. The breather study is going to be presented at CROI, which is a week on, weekend off approach using efavirenz. I know that adult colleagues are often quite taken aback by that, but there is a fair amount of desperation to try and find ways to support adolescents to adhere to their regimens. And also structured treatment interruptions have been studied. So looking at all these things, tailoring, as we've had to do or continue to think about, is not consistent with harmonization. But we really have to consider how much harmonization do we need, and if we look at it from various points of view, from the point of view of the caretaker, it certainly would be easier to have the same regimen for all family members and could avoid inappropriate drug sharing. The healthcare providers would be more familiar with, they are familiar with adult regimens, but we'll still need different formulations and different dosing for children, and the dosing has to change as the child grows and ages. We'll probably streamline procurement and simplify forecasting and ordering for the programs, and on a larger scale may help with reducing stockouts, and would likely be good for manufacturers, ensuring API availability and hopefully translating into lower cost of production. But if we really want to harmonize and get all the benefits, then it probably means that we have to look to develop scored dispersible adult tablets rather than just the regular formulation, so that you can actually go all the way down the spectrum to the youngest children. So we've talked a lot about efavirenz already. There's work underway in the pediatric community to sort of finesse efavirenz dosing in children, doing PK modeling. And when we look at the ENCORE trial, they did not include younger adolescents. So we really don't know about the efficacy of the 400 milligram dose for adolescents over 35 kilo. So that could be truly problematic, since the guidelines currently go all the way down. Whatever's recommended for adults goes through the adolescent group. As we've already discussed, low-dose efavirenz would have many opportunities, particularly for adolescents, by aligning with adults. And we like that one pill once daily, and presumably it'll have less CNS toxicity and enhance adherence. But on the other hand, we're pretty sure that we'll see underdosing as a result of the poor adherence we see in this population. And the higher dose may actually be providing a bit of a cover for those not infrequent missed doses. And we also see frequent unplanned pregnancies among adolescents, and if we're not fully suppressing in this group, we not only have the risk of drug resistance, but also of MTCT. So I'll shift quickly to the integrase inhibitors. I think we also are quite excited about this class of drugs, and there's dose finding studies underway. Dolutegravir has been approved from 12 years and up, and there are studies now looking at 6 to 12 and 2 to 6, with plans to go all the way down to the newborn. Raltegravir actually is a drug where we have good dosing and some reasonable formulations for children. That's been studied for a long time and still being studied in less than 4 weeks. And there's a large strategy trial for dolutegravir, studying it for first line versus standard of care and second line versus standard of care in a soon-to-be opened Odyssey trial. I think we're considering, and as the adults have, whether we need to wait for trials to use the integrase inhibitors in second and third line regimens, and even in first line, once we have the dosing, based on what's been seen in the adults. And that's sort of open question. Raltegravir, as I said, we have dosing down to 4 weeks. The pediatric formulation is pretty good for children 10 years of age, 10 kilo and greater, but there's a powder for suspension for children less than 10 kilo, which is not very user-friendly. It requires twice daily dosing. It has a lower genetic barrier than dolutegravir, and currently is a limited availability and clearly of limited interest for adults. So it's an option for pediatrics and something we've been talking about, but probably not favorable for harmonization. And depending on whether we can make it available, it may not be really worth considering. Dolutegravir, on the other hand, has a low dose per kilo and is good for infants and children with a higher genetic barrier, which is particularly good for those poorly adherent children and adolescents. We like the once-a-day dosing and the good toxicity profile, and at least for older children we have good formulations. But the FDC isn't ready. It's only planned in combination with abacavir. I'm interested that the abacavir hypersensitivity issue hasn't come up in the discussion so far, but I think needs to be considered. But overall, it's ideal for harmonization, but we're probably a few years off in the pediatric population. And then there's TAF. The current alignment with adults on the NRT backbone is only down to adolescents who are 35 kilo or greater due to concerns around tenofovir and bone toxicity. And TAF clearly has the potential for reduced toxicity and wider use, but it's only being investigated in children 6 years and older. And if the experience with tenofovir is any indication, it could be another decade before we have dosing information in children on TAF. The TAF full PIP has only been planned in co-formulation, and lack of single-strength approval is clearly a barrier to development of what would probably be a very nice fixed-dose combination of dolutegravir, TAF, and XTC. So again, it's ideal for harmonization, but not yet a reality. We had a PADO meeting, so it's a pediatric CATO meeting, and a couple of the outcomes of that meeting are identified here. Again, adolescents, they're the hot topic, but there are serious challenges of maximizing efficacy and adherence while preserving harmonization. And there's really a preference to move to more effective and forgiving regimens. Again, I said that there was a conversation around, and we're looking at whether PI should be started in, or integrase inhibitors first line for adolescents. Young children lack the formulations and dosing guidance, and that will remain forever key barriers to optimal use of drugs in young children. And in the second and third line regimens, we see a more prominent role of the integrase inhibitors, with raltegravir being a possibility at least until we have dolutegravir dosing. And again, everybody was most interested in a combination of dolutegravir, TAF, and FTC as the most promising option for the future. And at PADO, there was interest in doravirine as well. So current treatment options only allow for the limited harmonization. More information is clearly needed to support adoption of low-dose efavirenz for first line in the pediatric and adolescent populations. I've mentioned several times that there is great interest, particularly in dolutegravir and in a combination regimen that would allow full harmonization with the adults if we can achieve this FDC. But it'll only be possible if drug development for adults and children is aligned and synchronized while really considering the appropriate specificities around children across the whole age and developmental spectrum. And methodologic approaches or new approaches are really desperately needed to consider how to explore opportunities to quick up the drug development and formulation development for children and adolescents so that we don't continue to lag behind as we have over the last decade or two. Thanks.
Up there, and as we open up to, I guess this would be we'll start out with a few clarifying questions for Elaine, and it could work if we have everyone come up. We can move over a bit, all the speakers, and we can have a sort of a round table of questions. So, but first we'll start with pediatrics. So.
Hi, Ben Plumley from Pangaea. Elaine, great presentation. Thank you very much. A conceptual question of clarification for you. There seems to be such a tension in the pediatrics optimization field in that, on the one hand, there isn't the investment going into pediatric formulations that are needed. But on the other hand, as you rightly put in that third bullet point, there's a limitation to what can be achieved by harmonization. So there's going to have to be, as you said, tailoring, not harmonization. So how, as a leader in this field, how do you see the sort of the balancing of the harmonization versus the tailoring, and where do you think we're going to get the money from to be able to achieve that agenda?
I have no idea where we're going to get the money from. So I have to say, while this is somewhat, dour overall, that we have seen greater interest on the part of pharma to work with the pediatric community to develop appropriate pediatric formulations. I think there are particular developmental groups where we are going to have to stray from harmonization, but there are large swaths where we won't. And I think Di could speak well to advances around the use of nevirapine with all sorts of great pediatric formulations. But by the time we got them in, suddenly we weren't interested in nevirapine. So I'm not totally hopeless, but I think there is much more activity. It's hard. It's really hard.
Just, Trevor, you had a question before. Is that still relevant now for this one?
Yeah, if Elaine can comment, and maybe Di can.
Just hold one second.
The whole issue of pellets. I think you've been studying this in chapters 2. I just wanted to know where we are. One of the, I think the frustrations in pediatrics is just the speed at which we move with things, and so the adults are always ahead of us, and we continue to talk about the problems we have with the younger ones and what we might have, what we hope for. So I'm just wondering whether this was discussed in PADO 2 on all these investments that are ongoing and the studies that are ongoing on things that we've already agreed on, but we don't seem to be moving fast enough.
Di, do you want to respond?
Well, actually, I think I should let Mark say something first, because he's dying to. For it about the pellets, and I can comment as well.
Yeah, Elaine said it all. It's hard, really hard. It's maybe it's not a matter of money today. It's really getting things done. So for the pellets, the delay in the approval by FDA, the pellets developed by CIPLA, has been essentially due to a change of rules for FDA to approve this kind of products. So the approval is about to be given. I think it's within 2 or 3 months. So they will be available, and CIPLA is able to produce this in a massive scale, which we were not sure a few months ago, because it requires a massive industrial investment to produce these pellets. These are not taste mass pellets, and Dai will speak about the fact that taste is really the issue of this formulation, although it's very much better than the liquid formulation. And so the taste masking of these formulations is really, really, really hard, much harder than we thought. However, we have 2, so I'm talking about the collaboration between CIPLA and the NDI. We have 2 formulations now going in phase 1 adult studies, and so we hope to have taste mask formulation within a few months, which could very, very fast go to clinical trials, including in children. So maybe Dai, you want to comment on the taste?
Okay, very brief. There is a poster at CROI looking at the update of, but it is a real problem, and I mean what families say, the initial enthusiasm really, because they don't have to carry liquids around, etc., was rather more disappear by the end of the year. And it's also about emptying lots of capsules and worrying about whether the kids get all the granules. I personally don't think granules is the answer. We need dispersible tablets or even half of adult tablets. I mean, I just would say something about the fact that I think on the ground people are still voting with their feet and giving nevirapine. And actually the toxicity in under 3-year-olds is much lower, even if you give full dose immediately, triple combination. Maybe the efficacy isn't quite so good, but the issues around making available a separate entity like Kaletra for the under 3s, which doesn't harmonise, so you can't give the adult one at all. There are lots of difficulties with that, which Elaine has brought out. And at the moment, those baby FDCs are what people are more using. Maybe we'll get elimination, so the numbers of young ones will be so small before we get there, but we'll see.
Okay, I think I saw from here Polly, and then now I'd like to open it up for more general discussion, and I think focusing on things such as harmonization and how we're going to take some of the challenges from pediatrics and think about it for adults and not have two. I think what came out of Elaine's talk was very interesting, is how far do we have to go with harmonization?
This is me. Sorry, what I'm going to say is probably kind of spectacular hypocrisy, because I am one of the people that have said this, but I think we're putting far too much emphasis on TAF at the moment, and I do it as well. I think that the development plan that Gilead has currently, to me, I can't see how it could enable TAF to be included in future guidelines, because it's kind of switching studies, and with kids it's only going down to 6 years anyway, and with adults they're looking at intracellular levels, which the FDA says that they will. We haven't got Charlie Flexner here, who's Mr. Intracellular, but I don't understand how we're going to be able to have that drug unboosted, and we also haven't got Andrew Hill, and I think we're probably going to talk about this evening, but although, I mean, I've done it, we've all done it, we've all kind of stood up and said what a great drug it could be, and we could harmonise from infancy to adulthood. But at the moment, with the Gilead development plan, I just don't understand how we're going to get there.
Thanks, Polly. I just want to say we just looking at the schedule, we are a little bit behind. We have now 15 minutes left, not the 30 minutes that we had hoped for sort of a general discussion before we move on to the next session block on hepatitis, so please be aware of that. And I think we have like 3 or 4 hands right there. And please, if you have a specific question, if you want to make a general comment, that's fair. Especially if a question to any of the speakers or to WHO, please indicate it. Dave?
Mine is a combination comment question, and it's essentially asking, is this issue of harmonization somewhat of a false choice that is inhibiting our ability to move forward with a portfolio of products? If we look at efavirenz 400, for example, versus dolutegravir, the investment has been made in studying efavirenz 400. So, and we have probably 15 to 25 million patient years of experience with efavirenz. It may not be a great drug, but when we have 15 to 25 million patient years of experience with dolutegravir or with TAF, what are we going to be talking about in terms of those drugs having liabilities? And what opportunity do we miss if we don't put efavirenz 400 over the finish line? You know, to me, I think Francois made a great point when he said the guideline convergence may be a momentary issue. I think we do need to consider with 30 million patients on treatment for 50 years, let's be optimistic, we're going to fix the programs and we're going to keep people alive on treatment for a long time. They're going to need choices so that all of those patients can find drugs that they can tolerate and take every day for 50 years. I think if we don't take a portfolio approach and develop options, then we are limiting our ability to sustain this response for 50 years. Rilpivirine looked pretty darn good in 2011. You know, TAF is at the same place clinically. In 5 years, we're going to have exactly the same conversation about TAF. the studies are looking at a massive overdose of TAF. If you look at the intracellular concentrations of tenofovir from TAF versus TDF, and we're starting to see side effects, lipids, nausea. Those are going to be big deals when we have 15 to 25 million patient years on TAF. So, my question is this a false choice, and should we not press ahead with both aggressively?
Why don't we have 2 or 3 more, and then we see how we can respond to some of those. Anil, okay.
Hi, I'm Marcelo Freitas. I'm head of Care and Treatment Division in the Brazilian AIDS program. And I was just wondering, thinking about using integrase inhibitor in first-line regimen, and I was thinking that as a public health perspective, when I think about offering ART, I'm not offering first-line, I'm offering a sequence of treatments. And every time I skip the sequence, I'm going to lose years of life, people. So in this perspective, taking into account, in Brazil we only use integrase inhibitors as third-line regimen. Thinking about this sequence, first, second, and third line, once I put the integrase inhibitor in first line, what kind of changes would I have to have in this sequence? And would the non-nucleosides still be an option in another point of the sequence, or I would lose this option and I could not use it anymore? Thank you.
Okay, Marco will address this. Anil?
So I appreciate, Godfrey, the timing challenge. Again, Anil from Mylan. An update, 2 updates and a question. So one update is on pediatrics. Just to build on Mark's comment from DNDi, as another manufacturer committed to pediatrics, we will be filing a taste mask sachet of granules for lopinavir ritonavir this year, and the 4-in-1 next year. And we've tried to share that with a few partners in the room, but since I think not everyone had heard that, there will be at least another product available in the long list of products that need to be developed for children. Another update on efavirenz 400, building on Dave's point, again, just to share with people in the room, not a bias towards its use, but just in terms of the availability. The FDA has given pretty clear guidance on the use of Encore for the filing, and we as one manufacturer will be filing the product this year with the FDA and have a meeting with the FDA to clarify that. On price, which I appreciated very much that many people made the point that it shouldn't be promoted for the impact on price, but just to share transparently what that will be. We've agreed with CHI that the reduction in cost will be reflected in the reduction in price, so basically the price of the product will come down roughly 10%, and that's just based on price. On PK, again, some people in the room know this, Marta, who I've only spoken to by phone, but it's nice to see you in person, will be leading a trial that Mylan is going to be funding for PK data on pregnant women, which will hopefully be available in the timeline of the guidelines coming together, so that data hopefully will be available in some form. So those are just some updates on efavirenz 400. And the question I have to WHO, for building on the original presentation presentations by Meg and Marco, there's 2 considerations that I hope the guidelines will take into account from a manufacturer's perspective. One you've already spoken to, which is the licensed territories. So just to share, and there are people here, whether Poly, Chai, others, who know these agreements quite well, but there's a difference of 40 countries between the dolutegravir license and the TDF or TAF licenses. And we, as a manufacturer, with innovators like ViiV and Gilead and others, try to push for the widest possible territories. But if there's a difference of 40 countries, I think it's going to be really important to say what happens in that number of countries when they will not have access to a low-price generic form of a product. This isn't to say that we as a manufacturer don't want to provide it, but if the license doesn't allow it, I think that's a real issue that has to be dealt with in the guidelines. The second question to the WHO, as you think about the guidance, is on manufacturing capacity. So something that I don't think is well appreciated today is generics manufacture 10 times the volume of big pharma for ARVs in the world. So that's a significant difference. And the capex required, the capital expenditure required to make enough volume for 30 million patients is substantial. Mylan has invested, again, we're one of multiple manufacturers, and there needs to be many suppliers of ARVs in the market, but we've invested $250 million to get
Anil,
our...
you need to leave some time
Okay.
for the others, please.
It's just a question of manufacturing capacity. TDF 3TC efavirenz is 1,200 milligrams.
Okay.
Dolutegravir TAF FTC is 300 milligrams, and there's a big difference in terms
Manufacturing
of capacity.
We got it.
Thanks, Dr.
Jens?
I was just about to think that this was a marketing strategy for the
Okay.
various companies, but let's get back to science. My question is for Stefano. In relation to considering new drugs as part of the first line regimens in the updated version of the WHO guidelines, how will you consider the experience that has now developed into evidence, I suppose, that new drugs that is recently launched into the market, actually we don't understand their full profile in terms of efficacy and side effects until we have a considerable duration of exposure in a considerable number of people in care outside of the randomized pivotal trials that allow these drugs to get to market. Because I would think that that evidence, which have shown that drugs that we thought was the magic bullet, and I heard a lot about that from the speakers this morning, I wonder whether that is actually reflective of the experience we have had in the last 20 years in terms of new drugs, which I can remember over time. I've heard the same sort of very enthusiastic discussions around where subsequent evidence along the lines of what I explained actually modified that. Thank you.
Thanks. I think that's enough food for thought for the panel. I don't know in which order we want to start. Why don't we start with you, Marco?
Just to comment on Marcelo and I think a little what was said by I think it was Anil. When you discuss about the drug optimization or the characteristics of the drug or ideal drug, one of the issues really is critical about this sequencing approach. And the current formula that you have is that the core drug in the first line is the nucleoside, PIs in second line, and integrated inhibitor in third line. This is the current process. Then I'm discussing now is if you can start to change this considering specific trade-offs from the tolerability, availability, this regulatory story. I think it's part of the CADO3 discussion that will come there, or this kind of process that is starting now. But with the respect of this, I think the clinical experience with these regimens in second line is also important. I'm not sure if you have a lot of experience of non-nucleoside drugs in second line, at least in adults. Maybe Pete can say something, but it would be a critical issue to discuss. And imagine that if you move one of these drugs to first line, what would be the option in second line with efavirenz or even other non-nucleoside? I think it's very unclear what would be the possibility to have it. I'm not sure exactly if you have a confidence that it works because of this issue of genetic barrier and other aspects that should be considered in the discussion. But I think it's a matter for discussion. It's an issue for discussion, I think, but definitely it's not an easy answer. I think nobody can give, maybe in the audience people can say something, but definitely is a point to consider. But you need to imagine that the sequencing is becoming important in this discussion in population level, and you need to consider also what was said by Anil. It's not just about the science, but also how this process of regulatory aspects can really interfere, facilitate, or create a challenge for millions, not just about individual level.
Just briefly, I agree. I think that the sequencing thing is not as simple as we thought it was, and it's often based on our understanding of NRTIs. I think Ernest has taught us that it's not as simple as just you dump the ones and you move on to the next. I think there's a lot we need to learn from that. So it may not be as simple as the way we've certainly been teaching. Just to come back to Nikos, I didn't quite understand your comment about RCTs. I wasn't asking for RCTs. I think in first line, if we're going to move to dolutegravir, we have to sort out pregnancy, we have to sort out TB. Otherwise, I don't think any government's going to take you seriously, certainly not in my arena where those are the two big issues. In terms of RCTs for second line, as I said, I think you need to come up with a more compelling reason to put dolutegravir in second line in the lines of Ernest, because we've got a study which demonstrates blind sequencing actually worked really well, and I'm not sure what dolutegravir is going to actually add to all of that, particularly when we might be reserving these things for first line or for the third line, where it might have a better place.
Maybe just a quick point on the portfolio approach. I think this whole idea of choice is very important. That even though harmonization simplifies care from a provider service provider perspective, it's not always ideal for the patient. And I think, tailor-made care might be something we may have to look forward to if we really, as you rightly point out, are going to expect people to be on treatment for many, many, many years.
Yes, 3 points. One, to respond to Jens, I agree with you. My push towards, let's say, innovation was not saying we need to change the guidelines without having the data. I'm just saying that we need to push research and go in that direction. Also in the direction of having more options, because this is the real alignment of guidelines. I mean, I'm not saying the 25 options that we have in a sense, in a crazy way in our world, but of course, aligning the standards needs also to have more options and differentiate the patients without exaggerating. So I agree with you. And this is why my position for efavirenz low dose, fortunately it's gone. No, I'm joking. Is that efavirenz is not a perfect drug. We know. Kenley, you said this very well, and you said this. But it's did a great job until now, let's say. And I think that low dose efavirenz studies had to be done, but again, my position personal is that dose reduction may not be so a great advance in terms of cost reduction and lowering toxicities let's say to compare with the risks that we can go. So my wish would be to invest in research for the new options. And I would like just to say also that we need a little bit to balance, not to compare peers with apples. I mean, the endeavors are different. Reducing dose is one thing, looking at future for future options is another. And I just would remind you that EDCTP, for example, is a small thing, but it's there. They open their calls for innovative trials in therapeutics. The deadline is 15th of April for letter of intent. So I'm making a little publicity. I'm co-chair of the board. And I think it's an opportunity to do some interesting trials together.
So I just want to make an observation, particularly on Kenley, what you're talking about. I think we're seeing some tension between the individual versus the public health approach, and I think that some of the success of having 13.6 million people on treatment has been based on the simplification. Much of ART treatment globally is done by nurses that have been able to follow a very, you start with this pill and you change to this pill, and that when we start talking about, well, maybe this patient can get that and this patient can get that, I think that there's lots of risk there, particularly in a time of shrinking resources. If anyone has been in the Debbie Burke's cloud recently, we know that we're talking about flatline funding and that we are going to have to maximize what we can do. So while this is particularly around harmonization, I think there was a whole set of principles guiding the rollout and simplification and harmonization. And we shouldn't quite throw those out yet.
Absolutely not. Yes, I don't think I want to suggest that we throw them out, but that there should be a mixed portfolio approach and harmonization. I think the majority of people will need to be on a similar drug. I totally agree. But there will be other needs for specific populations, for specific lifestyles that will need to be met, where individualized care would need to be considered. And we know enough about caring for HIV and rolling out to ARVs, that we should not panic, that will complicate care. And lastly, I also just want to make sure the point that I wasn't trying to, when I talked about nevirapine, it's not the preferred choice, but that we would move on. to something better than efavirenz on nevarapine.
The big challenge really is for the future to actually resolve that tension between retaining the public health approach with very limited option, looking towards the 30 billion that we want to get on treatment by 2020, and obviously some of the patient observations that we have to deal with. We have to wrap up this session, but I would like to ask Meg, maybe you can address some of the specific WHO questions and also share a couple of issues on the way forward related to CATO, PATO, etc.
Okay, thank you. So I think this has been a really great session, and just responding to a few of the questions that came directly to WHO, what do we do in terms of dealing with the licensing territories and guidance to manufacturers. There's a whole other group of folks in our department that work on forecasting of ARVs, as well as, and they put out an annual forecast. They have a database on drug pricing around the world. And some of the new work on forecasting is actually looking at longer term forecasts that are not just linear based on the year previous purchasing, but really about the trends of potential new drugs that are going to come into the market. So we look forward to that. We're working with medicine patent pools on that. Joss Perriens and Vincent Javier Mary lead that work, but as soon as that's available, sometime around March, we'll be able to share that with you broadly. So we do try to keep our ears and eyes open about trying to give some guidance to manufacturers. But I think it's hard right now because I think what we've heard today is there's this real tension that we're feeling right now between this choice, or I like this idea of harmonization, is it a false choice? And we're quite happy with what we've been able to accomplish. I think we're really excited that there's so many people on therapy. And sometimes we try to mess with what's working, and do we really want to do that at this point in time, and what's the right way to intervene at this point in time? And clearly what I heard today is there's a lot of questions that are not yet answered. There's definitely some questions that have to be answered about PK with lower dose efavirenz, and we're hoping to have some of that information to bring into the discussions that will happen in the guidelines. But on the other side, we're starting to see that efavirenz 400 has fulfilled quite a bit of information that needs to be able to be brought to FDA and will likely be approved in the United States. So there's already stringent regulatory bodies that are happy with efavirenz 400. I think this idea that we only have one sequencing, that we go from NNRTIs to PIs to integrase inhibitors, may not be the right strategy. There's some thoughts that maybe the strategy is to give your best drug, your longest lasting drug first, rather than keep your strongest for later. Do we have any evidence to know if this will work in a public health approach? No. So do we want to take that leap? I don't know. So I think these are important questions that the guideline committee will have to address. And certainly we've been hoping, and from CATO too, hanging our hat on this idea that TAF is going to be this miracle drug, and that we're hearing more and more. A, it may not be readily available. B, it's not FDA approved. C, it's not in combination. I mean, there's lots of hoops that have to be jumped through before we even see this miracle next first line drug that could bump out what we call AAA, our easy first line therapy right now. So it may be that we're wishing for too much, and this group is really hoping to also make sure that the right studies are done, that they're done quickly, and that we're always considering the needs of the pediatric population and the lower, and those who need it the most in some ways at the lower weight bands, because it takes so long for those drugs to get down into the lower weight bands in the trials. So that being said, I think WHO has a lot to do. It won't be, and we're very happy to have all of your input. Our next steps are really going to be our guideline processes, and for those people, there are many in this room who will be part of those guideline processes, or they'll have opportunities to feed in to our guideline processes through other mechanisms. We will be able to discuss this, and I'm not going to say it's going to be easy. You can see already. We're trying to find the next best, if there is one, ARV for first line is going to be a challenge. The next best for second line as well will be a challenge, because we don't really have that blue pill studies done. We don't have it. And then in terms of CADO, I mean, I think those things are really opportunities for think tanks. It's not where we're making big decisions, it's where we're getting information in. And if we're not seeing movement in research, or if we're not seeing movement in industry or regulatory bodies, I think this is something that we have to call upon others to help us do some of that movement. Because as WHO, we may not be able to move we don't have a research portfolio of funding, one thing. We also cannot work directly with pharma to influence us. We can influence this through partners. So we call upon partners to help us with some of these issues.
Thank you very much. This brings us to the end of the first part of this morning. Please do not run away. Thank you very much to the speakers. We have a small change of setup here.
Introduction of pegylated interferon, and then with first DAs, and now moving up to oral interferon-free, possibly ribavirin-free combinations, achieving cure in over 95% of patients, suggesting that potentially the ideal regimen already could be there. The basis of the intervention comes from the hepatitis C life cycle, and you see that different targets for therapeutic intervention have been identified and have led to drugs which are currently licensed. And this includes NS3 inhibitors, NS5B inhibitors, NS5A inhibitors, and for those who are not so familiar with the sort of more and more complicated language around these drug substances, the German colleagues have developed sort of a guideline which basically says that if you have a protease inhibitor, it's a Previr. If it's an NS5A inhibitor, it ends with an Asavir, and otherwise if it's an NS5B, it's going to be a Buvir. And at least then when people talk about these drugs, you sort of at least know which target we're talking about. You see the timeline of the licensed hepatitis C direct-acting antivirals, and clearly from that point you can see that, and that's a little bit maybe in contrast to HIV, how fast these different drugs have been licensed. And really in 2015, in most places of the Western world, we now have really 4 oral combinations available, which would be the fixed dose litifister sofosbuvir or the Abri-3 drug combination, or sofosbuvir either in combination with cimetravir decladisvir, really allowing already for some competitive approaches here and choices within the treatment scenario. Now, as Jean-Michel so perfectly put it, at the end of EASL 2014, he said, well, we're really facing perfectivir because every trial we see has 100%. And so, again, sort of aligning to the question, is that what we have already where we are? And so really the task, how I understood from this talk, is really to speak about the remaining challenges and priorities and further research to really find out where are we really. And I think one of the most important things to remember is that obviously if you treat the simplest patient population, then that will have a tremendous impact on your overall cure rates. And so really it's all about the patient population you're looking at, and you have to be very sort of experienced in looking at these trials to really sort of gather what kind of patients are we talking about and where we are. And I think what we all would understand is that obviously patients who have advanced liver cirrhosis and those who have failed previous regimens, potentially even a DA-containing regimen, are probably going to be the toughest patient population to treat. And indeed, if you go into some of the data, and this is just one example, and this is a trial of several studies which looked at patients who had compensated cirrhosis, so per se a somewhat more complicated patient group, and then included also patients who were treatment experienced, and then if you extend that to those who have portal hypertension at a more advanced degree, which would be defined, for example, as a low platelet count below 75%, well then suddenly you can see that in this 2 DAA plus minus ribavirin combination, only 82% of patients are really cured, suggesting that indeed, even with the current regimens, there are remaining difficult to treat patient populations. And then obviously, if we learn from HIV, and I think this was sort of echoing through the different discussion points we had, simplicity is the main driver of the success of the ARV rollout. So the question obviously is, if we want to have a hepatitis C therapy which reaches everyone, it should at best be pangenotypic and have an impact also on the amount of diagnostic interventions we have to perform alongside of the administration of these drugs. And clearly what you can see here is that from those currently available drug regimens, most of them have a very strict licensing or indication only for specific genotypes, clearly not for all, and some of them in vitro have no activity against some of the genotypes, which are distributed in different prevalence throughout the world. So whereas, yes, genotype 1 may be the predominant genotype in the US and Europe, this is not necessarily the case in many of the other countries. And clearly, the advantage of a pan-genotypic regimen would be that we would need no genotypic testing prior to starting hepatitis C therapy. And clearly, if we would at best have one pill for all, obviously, that would deliver some attractiveness. This is from the Unit 8 report from 2013, looking at the evolution of diagnostics, and that's something I think we tend to forget, is that it's not only about delivering drugs, it's really also about how can we improve the pathway of diagnosis, which obviously has been very difficult because in the presence of antibodies, you don't know does someone really have chronic infection, so requiring a PCR technique to really confirm that it's not resolved spontaneously infection, but really still ongoing replicated hepatitis C. Then the drugs, because of their sort of strict activity to certain genotypes, requires genotype assessment, and then you will also have to do viral load quantitatively, because duration will depend potentially, at least for some regimens, on the level of viremia. And then also there were obviously these steps during treatment monitoring and post-treatment to determine treatment success. And clearly you can see that that adds to cost and obviously makes rollout therapy quite complicated, because it does mean drawing blood at different time points and different interventions and patients coming back and again to the clinic. And clearly the overall pathway would then, in the future, one would envision is that really there's only one test confirming replicated hepatitis C, and then only a test confirming treatment success should be the way forward. Genotype 3 infection, and many of you will remember that genotype 3 infection used to be, in the interferon era, one of the more easy to treat genotypes, maybe not as easy as genotype 2, but really better than genotype 1 and 4, and obviously that has changed, and several of the DAA combinations, which at least in Europe have an indication for genotype 3 treatment. This is not the case in the United States. You can see that as soon as the more difficult or challenging patient profile emerges, being cirrhosis and treatment experience, you can see that the overall cure rates level off to below 60%, really highlighting that we do not have the final solution for genotype 3 patients. And let me remind you that in countries where IV drug use is the main driver of hepatitis C transmission, there's a high prevalence of genotype 3, and also in the Asian region, you will find countries with a very high genotype 3 prevalence, India, for example. And then obviously, many of the regimens today still require ribavirin. And I think one of the messages from ASLD of 2014 actually was that at least many clinicians feel that ribavirin does lower relapse rate in the more difficult to treat patient populations. However, if you look at the safety summary of some of the trials, you will see that indeed the amount of patients who have significant hemoglobin drops below 10 grams per deciliter is significantly higher if you have whatever short duration of ribavirin exposure, and I think that sort of highlights why we want to get rid of that, because that means that you are required to do hemoglobin controls under therapy. And let me also remind you that obviously when you get in the real-world patient population, where patients are older, where cardiovascular disease is present more frequently, obviously dropping below 10 can cause cardiac pain, for example, or an episode of angina pectoris. So I think this is clinically meaningful, and clearly ribavirin-free is the goal for the future. And then I think we're also addressing issues in patient populations which have been missed so far in the overall development program. And one typical example would be the renal, severe renal insufficient patient population. And remember that many patients on dialysis, and particularly those also who either have or are waiting for kidney transplantation, hepatitis C plays a really important role also in graft allocation. And because of the issues of treatment thereafter, and interferon has been very challenging in that patient group. Sofosbuvir has a GFR restriction in the label, and so there's very, very little data. And although some of the drugs promise to be potentially used because of the elimination pathway, data from these trials so far is lacking. There has been a case series of 4 patients who, in down-dose sofosbuvir or cimeprevir combinations, have been treated successfully, but it does take a lot of expertise and clearly speaks against rollout at this point because of the complexity of administration in this patient population. One of the big questions is also shorter treatment durations, and I think that still remains an important issue. And Jean-Michel has this wonderful schematic cartoon which sort of addressed the issue of how long do we really need to treat. And remember, there were times when we sort of said, well, there's probably a minimum time of treatment duration. And he really sort of said, well, can't we just define it as a matter of potency of the drugs we're giving and the high barrier to resistance, which will in the end sort of define the time we need for successful treatment. So saying if you have a very potent combination of as many drugs as you can imagine, and some of these have such a high barrier to resistance that that will not occur, and your lower limit of quantification is reached within a couple of days, well then there will also be a shorter treatment duration. And I think one of the first trials which very nicely showed that was a synergy trial, which sort of went in a different direction than the sort of, you can't go shorter than 8-week or 12-week sort of trial data, looked at the combination of 3 drugs, 3 DAs, versus the phospholiposphere combination. So it was 6 versus 12 weeks. And as you can see from this overall summary slide of the overall cure rates, that indeed there was no difference between the shorter treatment durations when several DA antivirals were combined, suggesting that indeed shorter durations are very well feasible. And I think one of the interesting side analysis from this trial was a poster at CROI, which actually looked at adherence rates in the different arms of this trial, was able to show that really declines in adherence occurred after week 6, so really suggesting that in a more difficult real-world population, this could be very meaningful, as it seems to be much easier to maintain adherence during the first 6 weeks in that particular patient population. Failure to DAA-based therapy and emergence of resistance. So, so far the virologists have sort of proclaimed that we do not necessarily need resistance testing prior to treatment therapy, except for the time when we were still using symepivir and interferon-containing regimen, where the Q80K mutation was showed to have an impact, and that made it into the label. This may be less relevant when oral DAA combinations are applied, but we are seeing data from various trials, and one of them was in Seaworthy, that actually the presence of resistance-associated variants, and particularly in the NS5A region, did have an impact on the overall cure rates, which you can see in the bottom line, which was lower in those who had RAS present at baseline versus those who did not, and we've also seen that from some other studies. So really suggesting that potentially in failure this actually may play a role, and I don't think that we really know that yet completely at this time point. And the final point I want to make is that obviously also for prevention measures, clearly data is needed in acute hepatitis C, and particularly obviously in areas where transmission is currently occurring. And one of the presentations here at the CROI conference will come from the European the database looking at the treatment uptake, and that is obviously really leveling off as patients are no longer willing to undergo interferon-based regimens, and so clearly also oral treatment regimens are urgently needed, in particular under consideration that these are not reimbursed and licensed at the current time point, so patients who choose to be treated in the chronic phase will then also have a period of hyperemia where they potentially will be a source of transmitting to others. So in conclusion, what I try to outline to you is that many challenges and priorities remain beyond cost and treatment access, which need to be addressed before we really reach that perfect ideal combination. And I think what we have to be appreciative about is that the efforts around hepatitis C drug development have not stopped, and many new drugs are on the way, including quite a number which are believed to be truly pan-genotypic, and that includes the protease inhibitor class as well as the NS5A inhibitor class. There also are protease inhibitors with considerable activity also against genotype 3, and so I think the target product profile should clearly be in the interest of adherence and monitoring of therapy. I think should be ultra-short therapy between 4 and 8 weeks. Clearly that should come in hand with an over 95% cure rate. It should be pan-genotypic because that obviously will decrease your amount of pre-monitoring and pre-diagnostic workup you will have to perform. Clearly also in the sense of adherence and ease of administration of one pill regimen, and clearly without ribavirin I think is essential. And it should be suitable for all disease stages, so I think in whatever there is to come, it has to prove to work in patients with liver cirrhosis and previous non-response. And clearly, we also want to see regimens with no major drug-drug interactions for obvious reasons. Thank you very much.
Thank you very much. Please stay with us. We have time for a couple of questions, comments from for clarification. Yes, please.
Sorry, use in pregnancy, because I'm slightly unfamiliar about where people have got to, because clearly talking about curing the mother and preventing the disease in the child is something that must be high up, and I think that in some ways even things like, you know, the testing routinely in pregnancy and that whole agenda are things that I don't think they've quite caught up with the wonderful timeline you've got there.
Yeah, they're not in that timeline yet. But I agree. I mean, that's one of the issues. But I think we have to appreciate that the development speed of these drugs has been very, very, very fast. But I think it does come as a shortage of having data in surrounding studies. So remember that when the first drugs were licensed, some of them were done on the basis of phase 2 trials. So something, and I think so it's really a split thing. On the one hand, I think we have to appreciate that the regulatory authorities, particularly the European ones, said we basically want to allow access to these drugs, at least in cirrhotic patients who can't wait any longer, as fast as possible. But this does come at the price that actually a lot of data is missing. And as a function of that, we have, you know, when you start treating patients in clinical practice, it is 10 times more complicated than you would think from a 98% cure rate. And I think that's one of the clear points.
Yeah, just to add to that, David Burke from Nijmegen, Netherlands, is that the ribavirin, of course, cannot be used during pregnancy. So if you're going to treat pregnant women, it should be without ribavirin.
Can I take the prerogative of the chair? When are we getting rid of interferon altogether?
Well, I think we're already rid of interferon at this time point. I mean, we have 4.
Except that it's still in the WHO recommendation.
Well, if you take it beyond the WHO,
I'm asking you.
Yes, so if you ask me in clinical practice, would I still treat someone with interferon at this point? There is for me only one exception, and that is the acute hepatitis C, because that's the only group of patients where we have no reimbursement policy for these rather costly drugs. And so if someone says, I want to be, for whatever reason, treated now with a very high cure rate, then obviously interferon is still a choice. Outside of that, we do not prescribe that anymore, and the guidelines beyond, so the EASL and many other guidelines have made a strong case in trying to say we should not use these regimens anymore under consideration of the increased efficacy and safety of these new combinations, which are now there.
Thank you. Stefan, can you just brief us all just a couple of minutes on the plans for guideline updates?
Thanks, Gottfried. The WHO hepatitis program is relatively young, having started its activities in early 2012, and we've been working on all the various issues that have to be addressed to scale up treatment, and much of that work has been around normative guidance. So we issued our first ever hepatitis guidelines from WHO for hepatitis C in last April, and we're very happy that we were able to include recommendations for sofosbuvir and simipravir within a few months of their being approved in the US and in Europe. But it's just such a fast-moving field that we're beginning to update them, and we'll be sometime in the second half of this year should have our update guidelines that will this time really try to address combinations and try to issue recommendations on preferred combinations. So it's a challenge because of the limited data, comparative data across the different companies' products, and also difficult because of the resource considerations which need to be taken into consideration and the prices of these drugs. It's a field that's moving very, very quickly. So that's why this workshop really, this session today is so useful, because it's really, in many ways, hepatitis is the younger sibling of HIV and has to address the same issues. So these issues around drug optimization and what are the characteristics that we need to take into consideration in thinking about combinations, and that's really the point of the session. Just to put it in perspective, in addition to the normative work, we're working to make sure that the drugs are available, are on the essentials medicines list. So we have applications now pending for all the approved drugs on the EML, which will be updated in April. And working with an expression of interest letter to the generics manufacturers and others to get the drugs pre-qualified, as well as getting pre-qualification of diagnostics. So with this combination of work, we hope that WHO will really be in a position to have the documents in place and the tools in place to allow the scale up. So.
Small siblings should be up and running very soon. We have one more question, then maybe introduce the next speaker, please.
So just a quick question on diagnostics. I really appreciate that you brought up the importance of diagnostics. In our own MSF programs right now, we're looking at the overall cost of treating a patient being taken up about a third or more of it by diagnostics itself. And especially, as you mentioned, with pangenotypic therapy, we can do quite a lot of diagnostic simplification. But already I think that we may even be falling behind a little bit in recommending diagnostic simplification that we can do already with the new DAA therapies. So I'm just wondering if actually both you and Stefan could comment on what sorts of diagnostic simplification can happen now and what might be recommended in the new guidelines, because I do feel like that's something that a lot of programs are not necessarily looking at yet, and still following potentially old EASL or AASLD guidelines on monitoring, especially with viral load very frequently, which is very, very costly. Thanks.
Yeah. So I think we're getting more and more data which really shows that any monitoring of viral load under therapy just probably make no sense at all. But you know, in clinic, I have to say though, I have the feeling that we're doing much more viral load monitoring than we did in the old days, and that has a lot to do with when you get into the real world and you have patients who have failed their first dual DAA combination, and you know, sort of thinking of what is the best duration, and in this tremendous cost pressure, suddenly you're always trying emotionally to find back to a marker which allows you to say it's cost effective or would be a good time point to treat shorter or longer. So I think although it makes from the scientific data much less sense to do viral monitoring, I think we don't have this strong confidence yet, and I think we need to build on that. But I would predict that after the large phase 3 trials have been analyzed and showing that whether you're negative at week 2, 4, 6, it really doesn't matter, that we have to make a more bolder attempt there. Although clinical practice, I can tell you that they're still struggling with that.
I think the real point we need, at which we'll be able to simplify so we are truly pangenotypic, because I think the genotyping is one barrier, and the second one is the need for nucleic acid testing. So if we had a very high-performing antigen test that was on a rapid diagnostic test platform, we would be. So I think you're right that we need to think more about these, but neither of those things is present yet. Pangenotypic will be there soon,
But clearly it's an area we would like as WHO to convene with other partners. We started talking with Unitate. We want to talk with CHI and other partners to see what platform we can create. It is an area that deserves a lot of attention because without addressing some of those issues, we are not going to be able to create greater demand from the ground, and this will not, we will not move the agenda. Maybe we can introduce the second speaker.
Great. Our second speaker is David Rippin, Executive Vice President and Chief Scientific Officer for the Clinton Health Access Initiative. What is the approach with industry to move the hepatitis C optimization agenda?
I'm going to need Marco somehow. I've lost our location. You have a very organized desktop, but I've lost it now.
Thank you. I'm going to take a little bit of liberty with the topic I'm talking about and really focus on how not just industry, but we as a community plus industry work together to develop a treatment optimization strategy for the short, medium, and long term. And I want to say a few things. I mean, one, I think it's important to talk about treatment optimization and not drug optimization. I think to the points we just heard, and particularly with hepatitis, the drugs are going to depend on the diagnostics and vice versa, and we have to look at them together. I mean, if we try to draw analogies, if I look at the HCV space, we just discovered the AZT equivalent of HCV treatment. And we're moving into the discovery of heart within a year of that. I'd like to say two things. Number one, I think when AZT was discovered, there's a lot that's been talked about in terms of it not being ethical to withhold that drug from patients. It's given 3 times a day at 600 milligrams. I think today we would consider it unethical to give patients that same dose of the drug. I think we have to be willing to look at short, medium, and long term and do things immediately in the short term without letting them lock us into decisions that we have to live with for the long term. I'm going to talk about some lessons we learned from HIV optimization space. And based on the discussion this morning, I actually think the HIV community needs to refresh a bit with that, because I'm starting to hear more and more of the TB-style conservatism and protectiveness about drugs coming out, and I think that, we need to move away from that. So we've got a huge number of patients who have hepatitis C. If you look at the number of patients dying of hepatitis C and B combined, it's roughly the same number of patients that are dying of HIV. This is a huge issue. And I think the point I want to make here is just urgency. We absolutely should be setting an agenda for optimal diagnosis and treatment today. But likewise, we have to very practically look at what we can do today and scale it up as aggressively as possible. Number one, because patients have the right to it. But number two, when we get to those optimal diagnostics and drugs, you can only increase the size of your programmatic treatment by a certain % each year without completely overstripping the capacity of the system. And if we don't start building diagnosis and treatment capacity now, when we get our optimal drugs, they're going to sit on the shelf for a while before a lot of patients get them. So this is a busy slide, but I think the point I want to make is that we have guidelines, we have a lot of tests that are possible to run, but we have some very practical realities in terms of programmatic access to diagnosis and treatment that we have to address. And I think we need to talk about in the short term, thinking about some of the things that I heard in the last talk, where we look at making assumptions about prevalent genotype in a given country, treating presumptively, and other options that we have for programs who may not have access to RDTs, to viral load testing, to genotype testing, but do have the capacity to diagnose patients with hepatitis and provide them with drugs. So I won't spend too long on this, because I think we've heard plenty about the process we took in the HIV space to talk about how we set priorities. I think one important thing to take a step back and remind ourselves of is if we go back to 2002 and we look at what our programs are delivering in terms of care today, I think we heard in 2002 that pretty much every single aspect of our treatment programs was not possible to accomplish in terms of diagnosis, treatment monitoring, delivering affordable drugs, delivering the best drugs affordably. And I think we just have to make sure that when we set our priorities, we're looking at what's clinically the best for patients and programmatically the simplest to deliver, and not make assumptions based on current costs or access policies. I think we have to set our target and then solve the problems we need to get there. And again, I really want to emphasize that while we look into the future and look at what we really want ultimately in terms of a short course, single regimen for that's pangenotypic, rapid cure, we have to focus as well on what we have in the short term and making the most of it. For example, HIV viral load testing is scaling up very rapidly. All of that infrastructure should be able to be used today for HCV viral load testing. So whether or not that is going to continue to be the top priority in terms of hepatitis treatment in 5 years, we have to focus on it today. And coming back to the point about the interplay between diagnostics and drugs, I think what I've heard in terms of hepatitis treatment reinforces that it's even more important to consider the linkage between what diagnostics we can effectively make available to programs and patients and the drugs and the product profile for drugs that we set. If we don't want to be doing genotype testing, that increases the importance of a pangenotypic drug regimen. But if it's going to be simple to do genotype testing, and that's going to and different regimens are going to significantly benefit patients in the future, I think we need to take the long-term view and keep our minds open in terms of what that product profile is going to look like. Another point I would make is in HIV, there was an emergency response. A lot of people were dying, and we had to get the drugs out there, get the patient numbers on treatment. I think today we know that we need to keep people alive and in care for 50 years, and therefore the quality of care overall is important. It's not just number of patients that you start on treatment, it's number of patients in the case of hepatitis that make it all the way through their treatment and are actually cured. And I think we absolutely have to keep our eye on scaling up programs that deliver a cure and not just deliver drugs. And again, this reemphasized the importance of the connection between diagnostics and drugs. All right, so coming to the topic I was assigned, which is what can we expect industry to do, and how can the community work together with industry to best accomplish that? And we've heard quite a bit about product profiles this morning. What I want to highlight here is that clarity on product profile and development priorities benefits everyone in the marketplace, from suppliers to the treatment community, through a focus and risk reduction on the supply side in terms of which products are developed most aggressively and where we do our research to most aggressively generate the data to support treatment. And from the community perspective, because the result of that is faster access to products, faster access to accessible pricing for those products, and products designed for ease of programmatic scale-up. I won't spend a lot of time on this. I think the map of meetings that was talked about for HIV did look a bit like a portfolio of meetings as opposed to a portfolio of development. I do think it's critically important to walk a balance in terms of including industry at the table and setting product priorities, but also setting priorities as a community without industry bias. And that requires a combination of meetings and forums with industry and without, to make sure that targets are set without bias, but industry is an important partner in terms of understanding what those priorities are and how we go about developing them. So this is going to be my last slide, and I'll make a number of points here. And a lot of these were mentioned earlier. I think the point about broadest possible territory for access and consistency of territory between different companies' access programs was already made, and I think it's equally as important in the hepatitis space. And one thing I really want to focus on is expectations, not just around what countries are listed on various licenses, but expectations of industry as a whole. And I consider industry to be originator and generic combined in the HCV space, to register these products broadly and rapidly in as many countries as is necessary, and to make sure that more lucrative markets are not prioritized at the expense of access in less lucrative markets. And in the hepatitis space, I think that's going to be quite a bit more complex than in the HIV space, where there's going to be private sector and public sector care in the same set of countries, and the income status of patients in those different markets is going to look significantly different. So one thing I would really emphasize here is, and I know industry, both originators and generics agree with this, is that we need to expect more, not just of the licensing agreements that originators make, but also in terms of the license recipients' aggressiveness in actually making products available, registered, and affordable in the full set of licensed territory that they're given. And I think we need to look at the collective output and not just the short-term lists of agreements and theoretical population coverage. So I'll stop there for now.
Thank you very much. Please stay with us. Any comments, questions at this point? Yes, please.
Well, I am kind of curious, Jules Levin, NATAP. I am kind of curious, since you mentioned it's important to start planning now, which I totally agree. Maybe you and who could address briefly what you are doing now to try and scale up for screening, linkage to care, whatever plans you have.
Yeah, and so I'll answer with a few examples of what we're doing, and then I'll let WHO comment from the global perspective. Now, right now, from CHI's and a number of other partners' perspective, we are going country to country and finding country governments who are ready to start implementing treatment now. And we're looking country by country at whether they can make decisions on simplification of delivery that are reasonable. For example, in one country, 90% of the patients that we are aware of are of genotype 4. So in that program context, we are working with the government to develop a program that doesn't do genotype testing, but treats presumptively based on an assumption of genotype 4. That's not going to be obviously a practical strategy in every country, but I think right now we need to go country by country and figure out which governments are ready to scale up today and actually have the funds to do so. We didn't talk about funding and funders at all, but that's a big issue as well.
Just a couple of things that, in addition, just to respond to the question, in addition to what Stefan mentioned in our normative, sort of the guideline work, couple of other elements we are doing. We have started to work with governments really to sort of pick up on hepatitis and to start creating a platform in hepatitis. We, for example, worked with Egypt very closely. That is obviously the front runner in price negotiations, etc., and have been facilitating to some extent some of these discussions. We're working with other countries to start developing national plans and discussing this. Mongolia, China, very much. China seems to start moving. Indonesia and a few others. So really getting the momentum going in countries. The issue about access, pre-qualification was mentioned, so we're starting to include hepatitis drugs into our pre-qualification mechanisms, both for diagnostics and for drugs. And we also include hepatitis drugs in our price reporting mechanism, so that people know what's the pricing landscape, etc. We also have worked with our essential medicines department on a patent landscape, so that people even know what patents are currently in place, etc. And we are assisting, as I said, countries in some of the price negotiations that are currently taking place. Unfortunately, with one single company, largely at this point. But certainly more to come. We've also just, over the last couple of months, really generated a conversation around elimination of hepatitis C and B. As you probably know, we are looking towards 2030 now in the post-2013 Sustainable Development Goals, working towards elimination and defining what that means for HIV, for TB, for malaria. So we really are starting to generate a discussion about this thinking, this vision also for hepatitis. It might seem early for some, but really unless we put that on the table now and start committing, working with countries to commit towards global targets and national targets in this direction, we are probably losing an important opportunity as everybody talks about what's going to happen post-2015. So these are a couple of things. We have draft targets that we're starting to discuss with countries that will be incorporated in the first global hepatitis strategy that should be approved by the WHO member states, which are basically all countries in the World Health Assembly in 2016. So these are a couple of things. We are still trying to get more resources. Surprisingly, we thought that everybody would want to jump on the hepatitis bandwagon and just want to help us to move these bits and pieces of work. We are having some discussions with some donors, and some of them are quite promising. But still, it is an agenda that is largely unfunded, not only in WHO, but in the international partner world and partner environment. So it's a bit of a battle.
So we have another question back
There's another question back there.
Hi, Joe Tucker from UNC Project China. Thanks for the very interesting talk. And in the Chinese context, and in many places, people who inject drugs have problems with testing, linkage to care, retention. And I'd be interested to hear your thoughts about how we can learn from the case of HIV in terms of people who inject drugs and how to optimize DAAs in this sort of existing health systems today.
So I'm going to have to say I'm completely unqualified to answer that question specifically. I mean, I think there are things we can learn from TB treatment paradigms, things to do and things also not to do. And I think important lessons to learn on not assuming automatically that a patient group is not going to comply, but I really defer that to another speaker because I can't speak specifically to the IDU community.
The broader question of linkage to care and decentralization of treatment is very complex, and persons who inject drugs are the priority group to address because of their high prevalence. I think it's too complex a set of considerations. Certainly they're prominently featured in the guidelines as a priority group. I think we're also trying to describe what the models of care are where groups have, researchers, or rather programs have tried to make those linkages and provide those services, and we'll be issuing that as a publication to allow others to learn from it. I think that's it's a work that has to expand because I think it's really a priority group.
More broadly speaking, just to follow up, is we are just now starting to think what are service delivery models. If the drugs become available at a low cost, it's tolerable, fulfilling all those great characteristics as described, how can we get it to the number of people that actually need it? And just looking at the Egypt example that is great and promising, but we have very centralized care in hepatology centers, and care is delivered only by hepatologists at this point. And again, learning from the HIV story, we have to get it out of there. We have to get it into the hand of non-hepatologists. We have to get it out of the hand of doctors even in the future. And obviously, this is thinking that seems to be very revolutionary in the hepatitis world. But unless we have a platform that discusses this, unless we have some countries who are sort of doing some implementation, work in this regard, some early learning, we are not going to move. So this is another really important area that we want to work with some partners to sort of think through, work with some countries to try it out and to share the experiences and lessons learned. And obviously, the whole world of harm reduction and how to integrate hepatitis treatment into broader harm reduction services, linkages, etc., is a critical element in that regard.
Yeah, Ben Plumley from Pangaea. Joe, great question. Just as an observation, you might think about Tanzania, where we've supported the scale-up of the National Harm Reduction Program and are rolling out Hep C diagnostics and treatments within the context of the Harm Reduction Program. And so far, we're seeing fantastic engagement from clients. And Joe, you and I should speak offline, because with AIDS Care China, we're trying to do the same thing in a couple of southern cities in China. So,
okay,
I had one last question.
Mm-hmm.
It was left over from the previous presentation. If somebody had a crystal ball between all of our presenters for hepatitis C, when do you think we would have the target product profile? 2 years, 3 years?
Jürgen, give it a shot.
Well, I think the positive point of this is that whatever we've achieved today, we would have never perceived 3 years ago. So I think it's fair enough to say that if you look at the product characteristics we displayed, that I find it very realistic in the next 2 years to get these published.
Encouraging, we better plan ahead.
I would just add, I mean, I think we know what we have now. We can set best product profile in the short term for what to choose amongst what we have. And in the medium term, we know what's in the pipeline roughly, and we know what the different potentials are of different products in the pipeline. I think the long-term product profile may evolve as we see some of the shortcomings of existing treatments and newer products come into the pipeline. So, I think you can set a product profile today for products available today or coming soon. And I think you have to be willing not to marry that product profile from now forevermore.
Okay, thank you very much, Dave. We move on to our last speaker, and that's Tracy. Tracy Sworn, who is the Hepatitis HIV Project Director of the Treatment Action Group. And as Tracy walks up, and since there was a mention to the UNITAID document on, I think it was market and drug landscape, I really would like to propose everybody to look it up on the website. It's a fantastic sort of analysis, and Tracy has been one of the key authors together with others on that. So congratulations for this document as well. Tracy, please.
Thank you so much, and I'd like to thank the organizers for inviting me to give this talk. So I think the first thing is, what do people with hepatitis C want? They want to be people without hepatitis C. They want to be cured as quickly, as safely as possible. So I think we have to look at a bigger response. It's not just about drugs or diagnostics, although both those things are critical. We need more than one approach, and we really need prevention as prevention, not just treating people as prevention. Less than 2% of people who inject drugs have access to syringe exchange programs globally. There are 1 million infections or more each year that happen because of inadequate infection control. There's not a globally safe blood supply, and I think there's still a lot of work that needs to be done in parallel with scaling up these programs that's about prevention. And we shouldn't forget completely about developing a vaccine, although it's obvious that it's going to be tricky. It would be great to have one as well as treatment. And to speak to the earlier question about people who inject drugs, I think communities are going to have to really be involved in the design, oversight, and implementation of these programs, particularly because we're talking about generalized and concentrated epidemics, and those that impact marginalized communities, men who have sex with men, commercial sex workers, and people who inject drugs. So for now, simpler is optimal. I think it's fair to say that's where we are. And you've heard this from the other speakers already, that we need to move hepatitis C from the world of liver disease by simplifying diagnostic staging, monitoring, and treatment. And the right direct-acting antivirals and the right diagnostics will facilitate the rollout and scale-up of test and cure programs for people. And we're in an odd spot. When I heard the HIV half of this, I was thinking, all of you know so much more about these drugs. I've never seen so many choices without a lot of knowledge. So we really need an approach that's bold and practical to move forward. Unlike antiretrovirals, all the DAAs have come out in such a short time frame. It was only 4 years ago that proof of concept was reported for an interferon-free cure. There are 15 more DAAs in late-stage development right now. And unlike ARVs, almost all the information we have is from high-income country registration trials. So there are a lot of populations that are understudied or left out. And the regimens that we select for low and middle income countries will be selected without years and years of clinical experience, and that's where bold and practical comes in. So a key population that people don't think about so much: can we treat pregnant women, and can we prevent vertical transmission of hepatitis C? So I know the epi data is somewhat imprecise. All I could find was that global HCV prevalence among pregnant women is 1 to 8%. If you want to assume that there are around 150 million chronically infected people, that comes out to 1.5 to 12 million women. And the vertical transmission rate is 3 to 10% in HCV monoinfection. So we're talking about a really important thing here. And I think it's really important also to underscore that hepatitis C causes harm both to the mothers and the babies. It increases the risk for gestational diabetes. And mothers with hepatitis C are at risk for immune-mediated postpartum worsening of their own liver disease. Maternal HCV can increase the risk for preterm delivery, low birth weight, low APGAR scores, birth defects, and infant mortality. So that's a pretty solid rationale for doing what we can to address this sooner rather than later. So what do we have to work around now? Well, things are really complicated. We need way too much information right now. We need less. We have different lengths of treatment, genotype-specific regimens, and gaps in efficacy for certain populations. And we need to sort of smooth that out as we move forward. We really don't know much about what happens in low and middle income countries. There has been some work in genotype 4, but I think there's been a total of maybe 2 to 3 people with genotype 5 in the entire clinical development program for some of these drugs. And maybe around 50 or 60 with genotype 6. That's not really, I think, adequate. We may need ribavirin-containing regimens despite the considerable drawbacks for some populations, and it would be nice to figure out how to get along without it. And we talked about less need for viral load monitoring, but there may be safety monitoring, particularly for people with really advanced liver disease, who are the highest priority population to be treated. And we need more data about the safety and efficacy of these drugs in people with common and serious comorbidities. And then we need to get rid of all of these things and think about what we want to have. The opportunity to cure maternal hepatitis C, prevent vertical transmission. We need pediatric formulations. Long-lasting formulations would be great if we get to that point. That would even more simplify things. And we need a fixed dose, fixed duration regimen that's safe and effective across the range of host and viral factors involved with hepatitis C. Also, as the earlier speakers have said, there are a lot of questions out there about baseline or acquired resistance that haven't really been resolved. If we're saying, doing a genotype test can be really hard or viral load is too expensive, I think we really need to think about the first-line regimens that we choose, because we may really need second-line regimens. And we have the opportunity to really look across 4 classes of drugs and say, we can start people with this, but if it happens not to work, we'll need to follow up with that. And hopefully we can leverage some of the drug development that is going on to gain more answers to these questions in the absence of a public-private research partnership that HIV has benefited from for so long. And that's it.
floor is open for any comments, questions? Yes, please. So, somebody who hasn't had an opportunity yet, okay, please.
I just want to comment from you. A great talk by Tracy and everybody in Hep C. And I just wanted to comment that I firmly believe, and have for 10 years, that we could eradicate hepatitis C globally as well as in the U.S. But what I firmly believe we need is routine hepatitis C testing, not just baby boomers, not just risk-based. But I believe we need routines, which means everybody at least one-time screening for hepatitis C. Certainly, if you're in a risk behavior group, continuing to use IgE drugs, testing negative, you need repeat testing for certain groups. But I believe in routine Hep C screening, and I think that could be rolled out globally. Obviously, it wouldn't be easy. It's not even easy here in the United States. People don't even want to talk about it because we can't get anywhere with funding in the U.S. But it's a good concept, I think. And I think it would address the issue which Tracy raised appropriately in terms of preventing mother-to-child transmission. If you had routine testing, that would go a long way towards preventing that.
Please. Take a 2 or 3, and then Tracy, if you want to react.
A couple of questions. Thanks very much, Tracy. The first one was really in terms of, if you think about pediatric formulations, which you might need as part of a mother-to-child transmission prevention regimen, for example, there's a lot of pips sitting in there for thinking about licensing or developing formulations. And where would you start, Tracy? Because I think we really don't want to develop all of the drugs that there are for children. You can't actually do the studies to find the right dose, etc., with all of them. So that's one question. The second thing is, I'm thinking back to the 076 days of the zidovudin in pregnancy, which was kind of seen as quite a bold move. It needs that, doesn't it? Where would you do it?
Okay, these are tough ones. Dave, and then maybe back to Tracy.
So I don't want to distract from the focus on hepatitis C, but maybe take advantage of the momentum and also look at a cautionary tale, which is for hepatitis B, there is a vaccine, and mother-to-child vertical transmission can be stopped for 37 cents with a birth dose of hepatitis B vaccine, and yet we don't do that. So we're talking about developing the technology to be able to prevent hepatitis C vertical transmission. It costs 37 cents and we don't even do it for hepatitis B. Is there some way that we can take some of the momentum around the excitement that we have new hepatitis C cures and make sure we don't leave hepatitis B behind?
Okay, Tracy, do you want to react?
Sure. So thank you for the comment, Jules. Starting with a question about pediatric investigational programs, we start with what we know to be the best drugs, and we don't mess around. So I know that's a really short answer, but that's the best answer I can give you. In terms of where to do trials that will sort of demonstrate proof of concept about mother-to-child transmission, I think one of the key things is, I can tell you where I think, but the communities there and the women there definitely have to weigh in, and it's somewhat down to them. But Eastern Europe or in Central Asia, where there's a lot of young women with hepatitis C, it's really a priority for a lot of them, from what they've said to me, to be able to do something. I'm sure there are other parts of the world, Southeast Asia also, but again, it's community involvement that's really going to drive this. And Dave, to your point about how do we sort of leverage the momentum for hepatitis B, one thing that's interesting, I see this arc at the conferences I go to where it was like Hep C, Hep C, Hep C, Hep C, Hep C. And as Hep C is descending, because so many drugs have come out, two things are ascending: prevention of fatty liver disease and hepatitis B. So I think if we can hitch our wagon to the drug development star, we have a chance there. Thank you.
Thanks. Just an observation as well, based on what you were saying, Tracy. I think we are at a critical point where, given the rapid developments, we have the risk of having sort of a treatment anarchy and a very individualized approach again to treatment, which might be okay in the United States or in Europe or in high-income settings. But if really we want to get serious about access, I think we have to, and you've been saying that, get very serious about what are possible ways of simplification in terms of the regimens, in terms of drug delivery, and as has been said, of course, in terms of diagnostics. So I think we have this time window of these possible 1 or 2 years where really we have to do a lot of this thinking and a lot of this work. Otherwise, we might miss an important opportunity to really get the greater access. As it is now, we know that even though most of the great proportion of hepatitis C happens actually in middle and high-income countries, it is such that the access to DAs is really 95% of those who are currently having access to DAs is actually in high-income countries, and in the global south it's basically very, very little. And I think if you really want to change that in the foreseeable future, obviously a lot of this simplification has to happen, and a lot of the price negotiations will have to happen, and we didn't get to discuss that in greater detail today. But Stefan, if you have any final conclusion?
Or just to address David's point about hepatitis B, so I think that there definitely is a spillover effect, that there is a broader interest. And we will be issuing next month our hepatitis B treatment guidelines at the Asia Pacific Conference. But also in part of these discussions around elimination, or really profiling the importance of vaccination. I mean, there is a lot that's happened. 80% of children receive vaccine globally, hepatitis B vaccine, but a lot has to happen with around the birth dose, as you mentioned. It's a very effective and a very inexpensive intervention that's not being addressed. So,
so this really brings us to the end of this morning. Even though I'm sure we could have talked for another hour. I want to thank you all for coming. There's a boxed lunch out there, so please do get your lunch on the way out and have some chat. And I really also want to talk my own team who put this together. First and foremost, Meg, who took the lead in this. Thank you, Meg. Marco, Nathan, Ford in the back. Martina Benesato and Stefan. So I hope you all had fun. There's a lot more to come for many of us this afternoon, and let's look forward to a great conference.